Why it is a pregnancy of unknown location? Because there are three reasons. It may be we are seeing too late when the miscarriage has already occurred, or too early when it is a normal pregnancy, but developing, we are not able to see on the ultrasound, maybe delayed conception, or ectopic pregnancy is present, maybe it's too early to see, or we have missed it, not seeing the adnexa properly. The management will depend on the serial beta SCG and repeat USG scan. Neither of the pregnancy of unknown location or pregnancy of viability is not a diagnosis. It is just a simple step at that moment of time. Okay, the key points from my lecture is don't hesitate to do the transvaginal scan, and please write on the prescription transvaginal scan in a bold letter, because most of the people hesitate to do the transvaginal scan. Strict criteria and interval should be followed before diagnosing the miscarriage. All pregnant women should offer early scan between 10 to 13 weeks, because it is a very, very important scan to manage the pregnancy further. And the most important sign of ectopic pregnancy, it is a heterogeneous mass in the adnexa. Always suspect the ectopic pregnancy. These are my references. Thank you.
Thank you, ma'am. Ma'am, the lecture will be discussed. Thank you, ma'am, for covering the topic very nicely. Now I request that the topic is open for discussion. If there are any questions, we can ask ma'am.
Can you please elaborate on two different types of scar ectopics, type 1 and type 2? How to differentiate that on ultrasound, because the management varies?
Type 1. I will go to this. The layer of myometrium, it depends on the type 1 is when we see the gestational sac at the site of previous cesarean scar, but we see the good thickness of myometrium between the vesicovaginal fold and gestational sac. When this thin layer is absent, then there are chances of rupture, and we manage it mostly surgically.
Thank you, ma'am. Any other questions? Okay, thank you. Felicitation. Now I call upon the next speaker. Next topic in this session is first trimester NT-NB scan by Dr. Shripad Karade. I request Dr. Karade to please come on stage. Current HOD at Department of Fetal Medicine, KM Hospital, Pune. He has been trained at Mediscan, Chennai. His areas of interest are growth abnormalities and Doppler.
Good morning all. At the outset only I would like to thank OBGYN Society Pandharpur, IMA Pandharpur for giving us this opportunity, and special thanks to Sudesh sir, Kane sir. So I'll start with my topic. We all are already doing this scan with what we commonly call as NT-NB scan, or some people only label it as NT scan. See, few years back, our knowledge about first trimester ultrasound was restricted to very limited things, like seeing whether it is intrauterine pregnancy, CRL, heartbeats, and whether it is missed abortion, ectopic pregnancies. But now with advances in ultrasound, we can gather a lot of information in the first trimester. Four most important aspects of first trimester ultrasound are dating, aneuploidy screening, detection of fetal anomaly, and dealing with multifetal pregnancies. Out of these four, first three I'll be discussing, and multifetal pregnancy, my next speaker, Dr. Shweta, will cover. So why dating is important? Because dating helps us in many ways. Most importantly, it helps us to establish expected date of delivery. It helps us to plan the specific tests like double marker, triple marker, quadruple marker, even NIPT, amnio CVS, all these genetics related tests we need to be time specific. So for that purpose also, assigning gestational age is one of the most important and basic aspect of first trimester ultrasound. Second thing, it helps us to avoid postdatism, and it helps us to assess fetal growth in second as well as third trimester. Now, as we all know, the commonest method for assigning gestational age is based on last menstrual period. But women have a tendency to round off their LMPs close to 15. And there are multiple reasons that LMP is not a very reliable way of assigning gestational age, because there are other factors also like irregular cycle, early pregnancy bleeding, patients who are on OC pills. And finally, it comes to like certain dates are actually less certain. So we can't rely on LMP to assign gestational age. So now what is the best modality to assign gestational age? That is crown rump length. But crown rump length should be used for assigning gestational age only when it is between 45 millimeter to 84 millimeter. And the reason is before 45 millimeter, the embryo is hyperflex. So actually what we measure is neck rump length rather than crown rump length. So it will underestimate the gestational age. And after 84 millimeter, the embryo tends to extend more. So we tend to overestimate the gestational age. So if CRL is between 45 to 84, we can use it for assigning gestational age. So should we assign gestational age for all pregnancies based on CRL? No need. Many times we find that gestational age, when we calculate based on patient's LMP, that is different, and when we get a sonography report, the gestational age given by the sonologist is different. But when should we correct the dates? There is a simple way of correcting the dates. If the difference in gestational age assigned by LMP and CRL is less than 7 days, then go by LMP. If their difference is only like 2 days, 3 days, 4 days, do not correct it by CRL. But if the difference is more than 7 days, always go by CRL. So I'll come back. This is how the ideal CRL image should be seen. And almost all obstetricians now should ask their sonologists to provide this image in their report. Because if the CRL image is not ideal and if something like this is there, then we should not use this CRL to assign the gestational age. Now we'll come to aneuploidy screening. These three questions we need to answer. First is why we are doing this, whom we should offer this, and how we should do it. So why? See, we all know that Down syndrome means we all are made up of genetic material. If any gene moves from here and there, something can happen to the fetus. But we can't diagnose all genetic conditions antenatally. But Down syndrome being one of the commonest chromosomal aneuploidy, we have a screening method as well as confirmatory tests available to diagnose antenatally. The incidence is 1:600 to 800, and 9 out of the 10 survive for first year of life. 1/3 may have serious cardiac defects, and majority will have mental disability. So if we can diagnose a fetus with Down syndrome, we can offer an option of either termination of pregnancy or continuation of pregnancy. Now next question arises is, do we need to screen all pregnant women? See, the older concept was like only a pregnant woman about 30 years or 35 years should be screened for these kind of genetic abnormalities. But in a country like India, where most of the pregnancies are over before the age of 35, then if we will not screen those women, we are going to miss most of the Downs babies. So uniformly, we should screen all pregnant women for aneuploidies. Now there are various methods for going ahead for aneuploidy screening. The first important aspect of aneuploidy screening is maternal age. It means for every particular maternal age, there is certain amount of risk for that mother to have a baby with Down syndrome. Then now the most commonly used method is NT&B scan along with double marker test, what we commonly call as first trimester combined screening. It has two aspects. One is ultrasound, that is what we are discussing, NT&B scan, and second is biochemical markers. In NT scan, as I explained, is assigning gestational age based on CRL. Then second important thing is measurement of knuckle translucency, seeing for presence of nasal bone, then assessing ductus venosus flow and tricuspid regurgitation. So these are mandatory things in ultrasound if we are doing aneuploidy screening. And as far as biochemical markers are concerned, in first trimester we'll assess two maternal hormones, that is PAP-A and free beta HCG. So when we combine both these things, we label it as first trimester combined screening. Now here you can see, if we start screening pregnant women only based on maternal age, the detection rate will be somewhere around 30%. Now if you go only by biochemical markers, the detection will be somewhere around 50%. But if you combine all these aspects, then the detection rate goes to 90% with 5% false positive rate. Now this is an image which shows how knuckle translucency is measured. Again, I will request all the obstetricians that they should ask the sonologist to provide first image of measurement of CRL, then second image of measurement of knuckle translucency. Now this slide, I will explain you how NT changes the risk for aneuploidy. Now here the a priori risk means a risk based on maternal age is 1:963 for CRL 57 millimeter. Now if for this fetus NT measurement is 1.3 millimeter, the combined risk becomes 1:5350. So she is absolutely low risk, means this baby is like any other normal baby. Versus if now the NT is 3.1, for the same patient, the risk becomes 1:69. So she straightway becomes high risk. So this is how NT along with maternal age can change the aneuploidy risk. See, previously there were only two categories in the combined screening report. One was low risk, one was high risk. But in last 2 to 3 years, all the labs have added one more category called intermediate risk. So the cutoff which we use in India is 1:250. So if the combined risk is about 250, like 200, 150, 100, 80, 70, whatever, she will straightway fall into high risk category. If it is less than 250 and more than 1000, so like 1000, 1200, 5000, 10,000, she is low risk. But the window from 250 to 1000 falls into intermediate risk category. This image you can see nasal bone. Now as I have explained you measurement of CRL, measurement of knuckle translucency. Now it comes to seeing presence or absence of nasal bone. Nasal bone has likelihood ratio around 7. More the likelihood ratio, stronger is the marker. So nasal bone presence or absence drastically changes your risk assessment. Now, many reports you must have seen first trimester, they have given measurement of nasal bone like 1 millimeter, 2 millimeter. But as per the guidelines, first trimester only presence or absence of nasal bone is important. No measurement is required in first trimester. So first image you should ask in the report is CRL, then knuckle translucency, then nasal bone. Now this image, it shows as the NT goes on increasing, right, from 3.54 millimeter to more than 6.5, the incidence of chromosomal defects also increases from 21% to 65%. Now here I'll explain this slide. So if we screen pregnant women based on only mother's age, detection rate is around 30%. If you do only double marker, it is around 50%. If you do only triple marker, it is 60%. Quadruple marker, 70%. But if you do combined screening, like NT-NB scan along with double marker, the detection rate goes to 90%. So the best modality for aneuploidy screening in first trimester is always combined screening. It should not be only ultrasound or only biochemistry. Many labs, if they don't have a reliable ultrasound report, they will give you only biochemical risk. In that situation, it is our responsibility to explain to the patient that this is only biochemical risk and this is not a combined. Because otherwise you will be counseling the patient with prediction rate of 90%, where it will be actually around 50–60%. Now this I have already explained. Screen positive means high risk when the value is above 250, screen negative. Now if you get a report where the combined screening shows that it's a screen positive report, but remember all these tests are screening tests, none of them are confirmatory. So even if the risk is like suppose 1:5, 1:10, even then that does not guarantee you that this baby has got Down syndrome. So we have to go for confirmatory test. Now confirmatory tests available are two. One is chorion villus sampling or amniocentesis. Both have around 0.5 to 1% incidence of pregnancy loss. Practically, usually most of the operators take due care and do this, so we have not come across any pregnancy loss related to procedure. But even then, while counseling the patient, we still have to explain them that this is the possibility. If the report says it's a screen negative combined screening, no more testing is required, and you can reassure the patient that your baby is like any other normal baby. Now, as I said, if we get a screen positive report, then we should go for confirmatory invasive testing. So you have a patient whose the ultrasound report says that it was increased NT. Then you did combined screening that showed she is high risk. Then you go for karyotype that comes normal. Now patient will ask you only one question: doctor, is my baby normal? She is not interested in all your statistics, data or anything. So now the answer for this question lies in this slide. Here you can see as the value of NT goes on increasing, in spite of normal karyotype, the incidence of adverse pregnancy outcome is around 85%. So we have to explain to the patient that if NT was high, karyotype is normal, there are only 15% chances that your baby might be normal. And the reasons are, there are other reasons, other causes also for increased NT, like other genetic syndromes which we are not testing, or associated cardiac anomaly or structural defects. Now this we have already discussed: knuckle translucency, nasal bone. Two more markers, ductus venosus and tricuspid regurgitation. Most of the labs right now are not incorporating these two markers in risk assessment. But still, as far as ductus venosus is concerned, two things we have to see. One is increased resistance and reversal of A wave. Because even if it is not associated with a genetic abnormality, it still may give you hint that baby may have some cardiac abnormality which may evolve in your next scans. Same is with tricuspid regurgitation. Here you can see how a normal ductus venosus flow is seen. This is how a normal tricuspid regurgitation flow is seen. Now if tricuspid regurgitation in a chromosomally normal fetus, it still can be seen with in 5.6% fetuses without any cardiac defects. But usually this tricuspid regurgitation settles down by the time she reaches 19-20 weeks. But if you see it in the first trimester scan, you have to report it. So in second trimester anomaly scan, you will remember and you will actually recheck for the tricuspid regurgitation. And 46% of the fetuses with cardiac defect will show you tricuspid regurgitation. So even if it is not incorporated in the risk assessment, we should still assess ductus venosus and tricuspid because that will give us hint about cardiac status. Now I'll shortly cover biochemical screening. As we all know, double marker is PAP-A beta SCG. Detection rate goes to 90% if we combine it with NT-NB scan. Then triple marker test AFP, unconjugated estriol, HCG. Now ideally most of the people have already stopped using triple marker test because better is quadruple marker test. Now the question comes is double, triple, quadruple. What should we do? As I said, the best modality is combined screening in first trimester. And remember one thing, if you have done combined screening in first trimester, do not repeat triple or quadruple. Because very often it will happen that first trimester it was low risk, you do quadruple second trimester and she will come in intermediate or high risk. Then you don't know which report you should rely on and you will unnecessarily expose those patients for invasive testing. So if combined FTS has 90% prediction, go for it. If patient has missed that window, then you can offer her quadruple marker screening. Now timing for this triple quadruple is grossly to remember it is between 15 to 21 weeks. But ideally before sending the sample to lab, we should ask sonologists to measure fetal BPD. If it is between 32 to 50 millimeters, then only we should send triple or quadruple marker. Ideal time is always 16-18 weeks. And most importantly, triple or quadruple. Means triple to we should not offer. If we are offering quadruple, it should be only and only for singleton pregnancies. Multifetal pregnancies, they are not reliable and ideally we should not offer them. Again, risk cutoff is same, 1:250. Now here, you have a pregnant woman, you have done all the screening, she has increased NT abnormal DVTR, she is screen positive. Now what should we do? As an obstetrician, ideally we should refer them to geneticists because they go through that patient's family history, pedigree, and they are in a better position to counsel the woman. And in KEM, we are fortunate enough to have two great geneticists like Chaitanya Datar sir and Minal Agarwal to guide us through all these situations. But as an obstetrician, we should still know what to do with these patients. So we have to offer karyotype, like that is invasive testing. Then early fetal echo at 16 weeks. We may not be able to do detailed fetal echo at 16, but at least at 16, we can still rule out gross cardiac abnormalities. Then again, targets, early target scan means echo and target, followed by routine anomaly scan. And finally, I said if it is still normal karyotype, we have to explain that only 15% of these babies will be normal. Invasive testing, amniocentesis, chorion villus. Amnio should never be done before 16 weeks and CVS should never be done before 11 weeks. NIPT, I will just say in 1 or 2 lines because Datar sir, Minal madam will cover this. This is a non-invasive screening test. Currently, labs are offering this for many genetic conditions, but as per our geneticists, it is right now more reliable for 21, 18, 13 because that is where the data is mostly studied. And here it is performed on the cell-free fetal DNA circulating in maternal blood. So we have now covered dating, then we have covered now aneuploidy screening. But apart from this, one of the important aspects of first trimester ultrasound is assessing fetal anatomy. Because if a report says like only CRL, NT-NB, DVT or fetal heart rate, that is not a complete report, because there are many structural abnormalities which we can actually diagnose in first trimester, which will help that woman to take a decision whether to continue or terminate the pregnancy. Now what we can see at 11 to 14 weeks. These are the minimum structures we should ask the sonologist to see in first trimester ultrasound. Fetal head, where we should be able to see choroid plexus, lateral ventricle. Fetal stomach should be seen. Fetal bladder should be seen. Cord insertion we should see. We should see all four extremities, whether at least present or absent. Then we should see for any gross defect with fetal spine. PMT is pre-maxillary triangle, that I'll explain to you in next few slides. Then as far as fetal heart is concerned, at least in 4-chamber view, we should see fetal blood flow on both right as well as left side. Because if any one side is not showing blood flow, you can at least predict that this baby might be heading towards right heart hypoplastic or left heart hypoplastic. Apart from that, arches. Arches also we should assess, because we may not be able to conclude that what kind of cardiac anomaly is there, but it will at least give you hint that I need to reassess this patient at 16 weeks and confirm. Now these are the anomalies which are always detectable in first trimester. So that's the reason I said in first trimester we must assess fetal anatomy. Acronia, holoprosencephaly, encephalocele, omphalocele, gastroschisis, limb body wall defect, megacystis. And all these abnormalities have significant impact on that baby's life. So we should be able to diagnose it in first trimester only. Now there are certain other abnormalities which we may predict in first trimester ultrasound. In this slide, you can see an area demarcated with a blue line, that is called as intracranial translucency. Ideally, we should see this blue area in each and every fetus. But if this area appears obliterated on the scan, that should give you hint that there is something may be wrong with baby's spine. So we should assess the spine at that scan, as well as we should ask her for early anomaly scan to assess the spine. If this area appears to be dilated, then it might be heading towards Dandy-Walker malformation or posterior fossa abnormality. So that is how it is important. Now limbs, sometimes we may be able to diagnose club foot, ectrodactyly, polydactyly, but these conditions don't come in always detectable category. Now cleft lip, cleft palate. I'll go back a little bit. Here we can see one image PMT, that is pre-maxillary triangle. Just see the anatomy. There is a triangular structure above and there are two dots below. The two dots below represent fetus, mandible of the fetus. Now if we want to predict or anticipate cleft lip or cleft palate in first trimester, the anatomy of this pre-maxillary triangle will appear distorted. We may not be able to conclusively diagnose that there is cleft palate or cleft lip, but if you get the distorted anatomy of PMT in first trimester, we can call that patient again for early anomaly and confirm at anomaly, because both these conditions are associated with genetic abnormalities, some syndromic conditions also. So we have to offer them genetic counseling, and as per geneticist's advice, if required, further invasive testing also. Cyrinomyelia is one condition which we commonly call as mermaid babies, where to different extent the lower limbs are fused with each other. Then certain types of skeletal dysplasias we can anticipate in first trimester, but as I said, you have to give a lot of time to see this fetal anatomy. You can't finish this in 10-15 minutes and try to diagnose these conditions. That is not going to be possible. As I said, 4-chamber will give you idea about left heart, right heart hypoplastic. Arches will tell you about outflow tract abnormalities. Now we'll come to the most interesting aspect for all the obstetricians, uterine artery Doppler in first trimester. Almost everyone will ask the sonologist, give us uterine artery, give us uterine artery. Now, one thing I'll tell you, it is not that easy to assess uterine arteries in first trimester. And maximum time when we are trying to assess uterine arteries, we assess some different vessel. But the criteria to confirm that the vessel which you are interrogating is uterine is the velocity should be more than 60 centimeter. That only confirms you that that's a uterine artery. And if based on if the report says uterine artery high resistance, next step is to start ecosprin for these patients. But if we are going to start ecosprin for prevention of FGR or anything, remember that the prediction based only on uterine artery Doppler is 46 to 48%. So remaining 50% patients we are unnecessarily going to feed with ecosprin. So if we are going to follow Fetal Medicine Foundation prediction model, the prediction rate goes to 86%, and this model considers these aspects like maternal age, ethnicity, past history, mean arterial pressure, PI of uterine arteries, placental growth factor, soluble FMS like tyrosine kinase. When we combine all these, then the prediction rate goes to 86%, and then ideally we should start these mothers on ecosprin. So with this I'll conclude my talk. These are my inspirations, my wife and my daughter. One more thing I'll tell you, there is only one pretty child in this world, and every mother has got it. Now it is our responsibility to make sure that every mother gets the prettiest child. Thank you.
Thank you, sir, for the enlightening presentation. Now the topic is open for discussion. Any questions from the audience?
Hello.
Hello, sir.
Nowadays, this early NTNB scan, now people are asking for early pregnancy anomaly scan only. First trimester anomaly scan. So everybody should write early trimester anomaly scan rather than NTNB scan, I think.
Actually, sir, this terminology we all are using, we are labeling it as first trimester anomaly scan. But the standard societies have still not labeled it as anomaly scan.
In many lectures now they are saying that it should be.
Best option, as I said, we should ask the sonologist to assess fetal anatomy.
And everybody
Because
should.
if you label it first trimester anomaly scan, and if legally something happens, then we don't have any defense for that.
Okay.
Like second trimester, it's a standard terminology like TIFA scan or anomaly scan. But for first trimester, it is still not labeled by any standard societies.
Thank you.
Thank you, sir. In the current scenario of ART, embryo reduction is posing a lot of problem for biochemical screening. So, like, how should we approach such patients?
See, if it's a twins pregnancy, you can still go ahead with biochemical pregnancy, biochemical screening.
After even the embryo reduction?
No. Straight away twins
Okay,
where patient wants to continue with the pregnancy. Now, anything about twins, or even if you are going to reduce from twins to singleton, then biochemistry will not be reliable. Your screening will be based on maternal age, NT, NB, DVTR.
So medico-legally we are at risk and we have to explain it to the patient.
You have to explain all this before sending patient for screening. Ideally, sir, pre-test counseling has to be there. The patient should be explained that why we are advising her these tests and what information we are expecting from these tests. If everything comes in normal, then you can very easily explain to the patient that everything is fine. provided that the report fits all these criteria. But if anything is missing from this, or the report shows like intermediate, high risk, or anything abnormal, then best way is to refer them to geneticist. Because we are thinking only about 13, 18, 21, but they can think about all millions of genes and advise us. Yes.
Hello, 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 hello,
Yes.
hello.
Yes. We have to we have to explain it beforehand. Okay. It is must. Yes. We have to spend time with the patient to explain this before sending her for the test.
Hello, sir. I wanted to ask you whether the NTNB should be combined with the double marker on the same day.
If you go by the most ideal way, double or the biochemistry should be done by around 10 weeks, where the hormones are more reliable. But due to compliance issue and to reduce patients' visits to the hospital, the protocol which we all follow is sending it on same day. But if you can't send it on same day for some reason, then maximum the labs what advise us is up to 5 days. Maximum up to 5 days you can still send. Ideal this is within 48 hours, but max up to 5 days.
Thank you, sir. Any more questions? Thank you, sir. Now I request Dr. Sanjay Deshmukh, sir, our chairperson, to kindly felicitate Dr. Shripad Karade, sir. I request Dr. Pooja Pavle ma'am to come on stage, please. I request Dr. Santosh Doshi, sir, to kindly felicitate Dr. Pooja Pavle ma'am. Thank you, sir. Thank you, ma'am. Now, I would like Dr. Sudesh Doshi, sir, President, OBGY Pandharpur. Sir, kindly felicitate our chairpersons for this session. Dr. Sanjay Deshmukh, sir, Dr. Madan Kamble, sir, Dr. Santosh Doshi, sir. Thank you, sir. Now we'll move on to the inauguration ceremony.
Now we are beginning the inauguration ceremony.
hello, 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 check, hello.
I request the IMA President Dr. Sunil Karande to come on stage. Vice President Dr. Arjun Salunkhe sir. All the faculties from KEM Hospital, Pune are requested to come on stage for the Prajwalan. Dr. Ajit Gandhi sir, Dr. Chamaria sir, please come on stage. Dr. Sudesh Doshi sir, President Pandharpur OBGY Society, please come on stage. Dr. Sachin Pawar, Secretary OBGY Society, please come on stage for Deep Prajwalan. IMA Secretary Dr. Deepak Dhotre, Clinical Secretary Dr. Keskar, Treasurer Dr. Gujre sir. With this deep shlok, we wish good health and well-being to everyone. Now I request Dr. Sunil Karande sir to felicitate Dr. Shripad Karade. Dr. Shripad Karade is HOD Department of Fetal Medicine in KEM Hospital, Pune. He is trained at Mediscan Chennai. His area of interest are growth abnormalities and Doppler. This is a token of appreciation of KEM Hospital faculty from IMA Pandharpur and OBGY Society Pandharpur. Please, team KEM Hospital, please join Dr. Kadai sir. Thank you to the whole team of KEM Hospital Pune for joining and making this moment a special one. Dr. Sunil Karande sir, IMA President will be speaking. Sir, please share your experience in few words.
Hello. Good morning, everyone. On behalf of IMA Pandharpur, I welcome faculty members who came from the way of Pandharpur, Solapur, Kurdwadi, Akluz, to enlighten us about the recent advances in the fetal medicine. Welcome Organizing Chairman Secretary of FETOCON 2024. Welcome IMA Secretary, Office Bearers, Chairmen, Co-Chairmen of IMA Committee, all members of Pandharpur Obstetric and Gynec Society, our MMC Observer B.K. Dhotre sir, and all virtually attending delegates as well as present delegates in the hall. I am very glad to inform you that this is a second scientific session in my presidential period. During this my presidential period, which has tremendous response. So thank you all of you. Organizing chairman, organizing secretary and his team and committee members have taken so much effort to success this session by selecting the informative talks as well as the faculty. Special thanks to team of the KM Hospital Pune for collaboration with us and giving a wonderful academic session. I hope in future this will be continued and will get the more response for the further CMEs. Enjoy this academic team. Thank you.
Thank you, sir. Now Dr. Sudesh Doshi sir will be speaking and will be sharing his experience during the arrangement of program, arrangement of CME.
नमस्कार. फिटोकॉन 2024 याच्यामध्ये आपल्या सगळ्यांचं स्वागत आहे. फिटल मेडिसिन हा तसा थोडासा रिलेटिव्हली नवीन सब्जेक्ट आहे. या साधारण 10 ते 20 वर्षामध्ये तयार झालेला सब्जेक्ट आहे. आपण जाणतो की मेडिसिन सतत इव्हॉल्विंग ब्रांच आहे. पूर्वी एकच ब्रांच होती सर्जरी आणि एकच ब्रांच मेडिसिन. परत प्रत्येक एक सब्जेक्ट वेगळा होत गेला. ऑर्थो वेगळं निघालं, पीडियाट्रिक्स वेगळं निघालं. त्याप्रमाणे आपली गायनाक ब्रांच बरेच वर्ष एकत्र कुटुंब होतं, पण आता ते आपल्याकडे विभक्त व्हायला लागलेले आहे. नाव वी आर गेटिंग लॅप्रोस्कोपिक सर्जन्स, वी आर गेटिंग IVF पीपल, वी आर गेटिंग फिटल मेडिसिन. आणि त्यातल्यात सगळ्यात छोटा अपत्य अंडफळ म्हणजे फिटल मेडिसिन आहे. मे बी लास्ट ओव्हर 20 years इट हॅज स्टार्टेड डेव्हलपिंग. आणि आपल्यासारख्या पंढरपूर, सोलापूर सारख्या ग्रामीण भागात तर या 5-10 वर्षातच फिटल मेडिसिनचा सब्जेक्ट डेव्हलप व्हायला लागला आहे. अजूनसुद्धा आम्हाला ऑब्स्टेट्रिशियन्सना सुद्धा सगळं फिटल मेडिसिन काय हे कळत नाही, कारण आंतरराष्ट्रीय पातळीवर बऱ्याच गोष्टी, बऱ्याच घडामोडी घडत असतात. त्याच्यासाठी आपण बऱ्याच वेळा संलग्न नसतो. पण अशा फिटल मेडिसिनच्या कॉन्फरन्सद्वारे आपण मग त्यातलं आपलं ज्ञान वृद्धी करायचा प्रयत्न करत असतो. त्याच्यामध्ये माझा स्वतःचा अनुभव मी सांगेन की साधारणपणे 3 ते 4 वर्षापूर्वीपर्यंत फिटल मेडिसिन काय असतं, की ते कशाशी खातात हे मलाही माहीत नव्हतं. फक्त 1-2 सोलापूरला, पुण्याला असे कोणीतरी मोठमोठे लोक असतात जे फिटल मेडिसिन करतात, पण त्याचा आपल्याशी काही दूर संबंध नव्हतो, अशा भ्रमात मी होतो. परंतु ज्यावेळेस पुण्याचे जावई आपल्याकडे येतात, ते म्हणतात सर मग तुम्ही ट्रायकस्पीड रिगर्स बघितलं नाही का, तुम्ही डबल मार्कर बघितले नाहीत का. मग त्यावेळेस माझ्या डोक्यात दिवा पेटला की आपल्याला अपग्रेड होणं गरजेचं आहे आता. मग 2018च्या ॲमाऊसमध्ये महाबळेश्वरला संध्याकाळी मी, कराडे सर आणि डॉक्टर सचिन दगडे बसलो होतो. मी नुसतेच बसलो होतो, आम्ही काही घेत नाही. तर रात्री बसलो होतो. तर त्यावेळेस आमची चर्चा झाली, म्हणजे बसलो होतो तुमच्या लक्षात येईल, कारण चांगली चर्चा झाली. तर त्यावेळेस कराडे सरांनी मला सांगितलं की मार्च 19 KEMला फिटल मेडिसिन कॉन्फरन्स आहे, नवीन सब्जेक्ट आहे, तुम्ही या. मग मी आपलं गेलो. बऱ्याच त्यावेळेस स्टेजवर फिरायची हाऊस नवीन होती. तिथं डेलिगेट म्हणून गेलतो. पण त्या 2 दिवसाच्या कॉन्फरन्समध्ये खरंच माझ्या ज्ञानामध्ये खूप भर पडली. हे एक नवीन तंत्रज्ञान आहे, नवीन गोष्ट आहे आणि आपल्याला ते शिकणं, आपल्याला त्याशी अवगत होणं खूप गरजेचं आहे. मग तेव्हापासून मला थोडं अल्ट्रासाऊंड समजायला सुरुवात झाली. मी 2004 पासून अल्ट्रासाऊंड करत होतो. मला वाटायचं मलाच काही कळत नाही, पण नंतर माझ्या लक्षात आलं की माझं मशीन लहान आहे, त्या मशीनला काही दिसत नाही म्हणून मला कळत नाही. आणि अर्थात मलाही ज्ञानवृद्धी होणं गरजेचं होतं. सो फ्रॉम लास्ट 3-4 years वी आर डुईंग टॉकिंग लॉट ऑफ फिटल मेडिसिन. त्याच्या गोष्टी येत आहेत. आपल्याला बाळातल्या ज्या काही गोष्टी आहेत त्या लवकर समजायला मदत होते. त्या दाम्पत्याला, त्या कुटुंबाला चांगलं बाळ द्यावं, त्या बाळाविषयी बरीच त्यांच्यामध्ये मनात शंका असते, आतुरता असते. माझं बाळ नॉर्मल होईल का, त्याला काही अडचणी आहेत की नाही. तर त्या संदर्भात त्यांचं समुपदेशन करणे, योग्य वेळी मार्गदर्शन करणे आणि योग्य तज्ज्ञ माणसाकडनं त्याचं निराकरण करून घेणे हे गरजेचं राहतं. मग त्या अनुषंगाने फिटल मेडिसिनची कॉन्फरन्स आज आम्ही पंढरपुरात घेत आहोत. आपण सगळे या ठिकाणी आलात, मोठ्या संख्येने त्याला प्रतिसाद दिलाय. मला सांगायला आनंद होतो की IMA पंढरपूर आणि पंढरपूर OBGYN सोसायटी यांच्या संयुक्त प्रयत्नामुळे आम्हाला जवळजवळ 250 ते 250 रजिस्ट्रेशन्स मिळालेले आहेत. त्यातले 50 ते 60 लोक ऑनलाईन जॉईन होतात, बाकीचे तर प्रत्यक्ष जॉईन होतात. आणि हे एवढे रजिस्ट्रेशन सांगतात की बाबा फिटल मेडिसिन किती महत्त्वाचं सब्जेक्ट आहे आणि त्याविषयी लोकांना किती आतुरता आहे जाणून घ्यायचे. तर याच्यामध्येच या कॉन्फरन्सचं सक्सेस आहे असं मला वाटतं. मला इथं बोलण्याची संधी दिली त्याबद्दल सगळ्या संयोजकांचे, त्यात मी पण आहे, आभार. आणि आय वुड लाईक डॉक्टर श्रीपाद कराड टू से समथिंग मोर अबाउट KEM फिटल मेडिसिन अँड अबाउट जनरल फिटल मेडिसिन. थँक्यू सर. थँक्यू.
थँक्यू सुदेश सर. ॲक्च्युली जसं सुदेश सरांनी सांगितलं की नोव्हेंबर महिन्यामध्ये आमची KEMची कॉन्फरन्स होती आणि तेव्हा तिथे भेटल्यानंतर आमचं असं जस्ट डिस्कशन झालं की आपण असे इव्हेंट्स घेतले पाहिजे टू जस्ट स्प्रेड द अवेअरनेस. अँड देअर इट वॉज डिसाइडेड की इन पंढरपूर विल हॅव 1 CME. पण हॅट्स ऑफ टू हिम अँड काने सर की ज्यांनी दे टूक रिअली अ सिरियस इनिशिएटिव्ह and they managed to organize it in less than 2 months' time. Because I have gone through organizing conferences, it's not that easy, but hats off to their efforts. Plus, I should be thankful to OBGY Society as well as IMA for providing such a great stage for Team KEM to come and share our knowledge or views about this specialty. Now about KEM Hospital, we started fetal medicine unit in 2015. I was the first fetal medicine person who started the department. Then Dr. Shweta joined, then Dr. Ashwini joined, then Dr. Pooja. We all are trained from Mediscan Chennai. And we desperately needed geneticist help. So for me, from day one, Chaitanya Datar sir was there. And I, being very new in this specialty, many times I used to ask very silly nonsense questions to him, but very patiently he used to guide us that time also. Then later on 2021, Dr. Meenal Agarwal also joined. And as I said in my presentation also, that's the biggest asset for my department, to have 2 geneticists who are available 24/7 for all our patients. Now slowly as the department grew, now we realize that there is significant increase in number of twins pregnancies, and that too complicated twins pregnancies. So we needed to address that issue. As far as dichorionic twins are concerned, usually we are not bothered much because they are two separate babies growing separately. But when you come across a monochorionic twins kind of situation where there are possibilities, a lot of complications also, and usually the concept in our area was like you find a MCDA twin, if the babies grow well and reach term, well and good. If anything happens, terminate the pregnancy. But there are a lot of therapeutic options available for these patients also. And all our patients we used to send to either Bangalore or Chennai. But most of them, because of financial reasons or logistic difficulties, could not reach there, and they used to terminate the pregnancy, which actually we could have saved. So recently on 17th November, we all launched a specialty twins therapeutic unit at KEM hospital, where we are already started managing complicated twins, like all therapeutic procedures we do there, including invasive testing, intrauterine transfusions, laser ablations for twins, then radio frequency ablations. The Dr. Shweta will cover during her talk also. So you all can support us to maintain that department. Plus that will be helpful for all the patients' benefit. Economically also it will be very cheaper compared to going them to Chennai or Bangalore. And from our side, we'll try our level best to give the best possible outcome to that patient. Now from KEM side, I would like to felicitate your OBGY Society and IMA members as a token of appreciation. Thank you very much to all for this kind gesture and all your support. Thank you very much.
Thank you, sir, for sharing your experiences.
Thank you, sir. Hello. Thank you, sir, for those kind words. And the KM team, we are thankful to you all for coming here. Now moving on towards the next section, session number 2, we'll discuss the first topic. The topic is Approach to second trimester anomalies by Dr. Ashwini Jaybhai Madam. I call upon the chairperson for this session, Dr. Archana Shah Ma'am. She is a consultant gynecologist in Solapur. She has done her diploma in reproductive medicine from Kiel, Germany, currently practicing at Deep Super Speciality Hospital, Solapur. She is a director and fertility specialist at Solapur Infertility Clinic. I request ma'am to please have a seat. Our next chairperson for the session, Dr. Vinod Shetty. Sir is a consultant gynecologist in Akluz at Shetty Maternity Home and Laparoscopy Center, current president of Akluz OBGY Society, director of Akluz Test Tube Baby Center, and special interest in IVF, sonography, and high-risk obstetrics. Dr. Ashwini Jaybhai ma'am, she is a MBBS DGO. She is a fellow in advanced OBGY ultrasound from Mediscan Chennai. She is currently associate consultant fetal medicine in KM Hospital Pune.
Hello everyone. So at itself the topic is a very vast, so we are not going to go into the details of the anomalies, but the approach when we get something abnormal than the normal is what we are trying to figure it out. I hope I will give justice to the topic. So when we do the anomaly scan, our main objectives are to predict with the confidence the structural normalcy of the fetus and identify which are severe and lethal abnormalities. But as we say with the inverted pyramid now, so we want to diagnose them mainly at the first trimester, as Dr. Shripad explained, and to raise the suspicion of the abnormality which need further testing and maybe need a follow-up scans. So when we do as per the ISWOG, we do it as in between 18 to 22 weeks. And ISWOG has laid down the recommendation for the performing the mid-trimester scan. But while approaching the method which we use, the key is the rule of three concept. With this, we can possibly see all the aspects of the fetus that we are expected to see while doing the anomaly scan. So when we do the examination from head to toe in a systematic way, it is less likely we miss the common anomalies which we want to see. And this is a 7-step process in which we see 7 plus 3, we call it as a concept. So it all starts with the history. Without history, there should not be any anomaly scan. Because sometimes the fetus structurally might be normal, but there is a family history of the genetic disorders which may not be evident on the ultrasound, and they evolve later, and those things are must addressed at the first visit of the obstetric, at the first obstetric visit. So we can plan throughout the plan the pregnancy. So history is very much important. Second, while starting with the scan, we do the survey of the fetus, so that we can plan, so that we will get an idea where is the placenta, how is the baby lying. So that will reduce the timing of the ultrasound scan. And then we do the standard biometry, which we see for the growth, and targeted imaging, which we'll be discussing the later. So that will give us an approach how we are going to get the abnormalities. And most important thing, while doing the scan, we have to see for the fetal activity. How is the fetus? There should be active flexion, extension, and how is the environment like her? Because everything is counted, and it's not the one pinpoint diagnosis, but when we put all the things together, then we can only conclude and we can plan for the further. And all the steps, which are the first 6 steps, we are concluded in the reporting. So this is a flow chart, which is, you can call it as a checklist while doing the ultrasound scan. So it will be good if we have the checklist and we keep ticking when we complete with the system-wise. So that will give us a feedback. We are not missing on some important aspect of the scan. So from head to toe, when in head we see 3 structures, that is what we call it as a rule of 3. We see the head in the 3 planes. And that is the transthalamic, transventricular, and transcerebellar plane. Spine we see in the 3 sections: spine, sagittal, transverse, and coronal sections. Thorax we see for the 3 structures: ribs, lungs and heart, and diaphragm. In neck we see for the nuchal fold thickness, any neck masses. Face we see in the 3 structures: orbit, nose, and mouth in the sagittal plane. So coming to the fetal heart also, we'll see in the 3 structures: outflows, inflows, 4-chamber views. Abdomen, we'll see upper, middle, and lower. And same with the limbs. We see all 3 segments of all 4 chambers, fetal environment, not but the least is activity, and the cervix. So in the head, when we see the 3 planes, that is a transthalamic plane, where we take the BPD and head circumference, is a transventricular plane, where we will see the CSP and transcerebellar plane. So coming to to diagnose the abnormal, first we should know what is the normal. And when we get to learn to know what is normal, abnormal picking up is easy. We need not to go into detail learning abnormal, but when we learn the normal, we can always have a second opinion scan. So while doing scan, so in the transthalamic plane, what we see is the shape of the skull, echogenicity, and the structures we see are the midline falx, thalami, and lateral sulcus. So once I know the normal, once I see all these planes, I feel, okay, it's not normal. It is looking something else. Here, the skull vault is absent, so it's an anencephaly. Ideally, it is a first trimester diagnosis. But in case if the patient has not done the first trimester, it should be picked up at the second trimester. When the shape is abnormal, it is called as a lemon-shaped skull, which we see in the Arnold cherry malformation. So whenever we raise something, okay, no, the continuity is broken, there is some mass, it is occipital encephalocele in this patient. And not but the least, if we observe here, so when we see the head of the fetus, the near field, which is the near to the anterior calvarium, is always a blood. That is called as a reverberation artifact, ultrasound we get. It is because of the bone echogenicity. But when I see the head which is very clear, I can see the near field also very clear, I should not be happy. It should make me worried, okay, something is abnormal because I'm seeing the near field also very clear. It's not normal because it represents the hypomineralization of the skull. So, and when there is an anatomical difference, see, I am not able to see the midline falx. So it is pointing towards the holoprosencephaly. So normal, identification of the normal is the most important thing. So when we go to the transventricular plane, we see what structure we are seeing is again the shape, echogenicity, cavum septum pellucidum, which is like a C-shaped window. Then we will see the frontal horn and occipital horn. Occipital horn, we have to image it clearly because we will measure the lateral ventricular diameter over there at the glomus of the atria. And we should know the rule of 10, it should be less than 10. Then it's normal. But what if I get this kind of picture where the diameter is increased, which is more than 10, or this, I'm getting too much big. I'm seeing only choroid plexus and so much of the large, big dilated ventricles, though they represent the ventriculomegaly. Gross ventriculomegaly, no problem. It's straightforward. We can go for the further testing and evaluate. But counseling, what it makes is difference when it comes to the mild ventriculomegaly, that is 10 to 15. So 10 to 12, they are associated with the mixed outcome. So they will progress. They will associated with the CNS abnormalities, and there will be some fetus will have abnormal karyotype association, and there is postnatal delay, what is the most important thing? The patient brain normal hai na, so how much we can predict? Mild is not, they are not the cases directly go for the termination. They need evaluation because sometimes infection also can be associated. So once I know the, going back to the normal transventricular plane, I want you to get familiar with this plane. It's a normal transventricular plane where I can see the midline falx, lateral ventricle, but what if I get this kind of transventricular plane? Because in this plane, what is different? There is absence of CSP. That C shadow from the normal, I'm not able to see. Even the lateral ventricles, they are disproportionately dilated. Frontal horns, what we see, they are looking like a pinch, which are, yellow astratics. So, when there is any deviation from the normal planes, because had only 3 planes are sufficient to conclude as a normal, that might go into abnormal. But these 3 planes, if they show something abnormal, we have to go for additional testing. Like in the scan, instead of axial plane, I'm going to the mid-sagittal plane, where I can see the absence of corpus callosum. And if I put a color Doppler to it, I will see there is absence of pericallosal artery, and then I can conclude my diagnosis. Okay, it is a agenesis of the corpus callosum. So knowing normal is the most important thing. Coming to the transcerebellar plane, how the normal transcerebellar plane is going to look in the mid-trimester is where we can get the dumbbell-shaped cerebral hemisphere, which are connected by the little more echogenic vermis in between, and there should not be any space. The 2 dumbbells, they should be connected, and we can see the cisterna magna, and here we will take the NFT from the outer aspect of the calvarium to the skin, where we measure the nuchal fold thickness and TCD. Till 16 to 24 weeks, it will correspond, okay? And if we little bit angulate, we will see the 4th ventricle. Now everyone is familiar with the transcerebellar plane, I hope so. So what if I get this kind of cerebellar plane? 2 dumbbell shape, but they are not connected with each other. There is a connection between the cisterna magna and 4th ventricle. Again, I will get the same kind of picture, but this is of different features. Here also cerebellar hemispheres, they are separated, but there is, along with that, I can see this dilated cisterna magna. So what it could be? Is the two cases are same? No. In the first, there is a 4th ventricle communicating to the posterior fossa, and the diagnosis is a black pouch cyst. And whether need patient to be anxious? No. They, most of the time, they are resolved, and there is not much clinical significance to this. But when it is a dilated, there is a non-communication. But here, case diagnosis is the likely Dandy-Walker malformation. How come? If the 2 are looking same. So because in which when we do the additional testing, we will see when we this kind of picture, we will see for the brainstem vermian angle. If it is less than 30, it will more likely I will get the black pouch cyst. When it is more than 45, it will go into the Dandy-Walker malformation. And so this is how we measure in the mid-sagittal plane. No need to go into detail because you can always refer the patient, but this chart makes all the difference between the 2 cases. So 2 things might look the same, but they need an additional testing so that we can come to conclusion. This is what is we needed. 3 standards plane, any deviation from the normal, we should evaluate further with the extended neurosonography so that we will come to a conclusion, and accordingly we will plan further testing. So coming to the spine, when we see the normal spine, we'll see in the sagittal plane, coronal plane, and axial plane. Here, in the first picture, we see the sagittal axis with the cervical and thoracic spine, and second picture is the thoracic, lumbar, and sacral spine. What we see more is we call as a tram track appearance. When while imaging the spine, the most important thing, whenever you are seeing the spine, there should be some amount of liquor over it. The skin over the spine should be continuous with each other, and there should not be any missing vertebra or joint vertebra. And when we see it in the axial spine, no need to document every time, but we have to sweep in the live whether all the lateral process of the spine, they are coming to each other. They are always towards making an angle towards each other. When we see them widen, that is something we can miss the occult spina bifida and all. So sagittal we document, even that axial sweep should be seen in the real time. So is it a normal spine? No, because when we see the skin above the spine is not regular, there is something coming out over here which is like a popping anechoic. So this is a case of meningocele. When I see in the axial plane, same patient, then I can see there is a lateral processes which are wide open, and there is a gap, and skin over it is a irregular one. So this is called as a splaying of the posterior ossification centers. And third case, skin is intact. Then what is missing? There is a missing vertebrae. So this is a case of sacral agenesis or loss of sacral segment. Now coming head to toe, head is done, spine is done, we'll come to the face. The face, these are the standard images while documenting the normal face. First is a mid-sagittal, what we call as a profile view. Second is orbits we'll see in the axial plane, and coronal plane we will see the pre-maxillary triangle. We call it as a PMT. And coming towards more anteriorly to pre-maxillary triangle, we will see the nose and lips. So I want to make an impression. See, ultrasound is a picture memory. So if we know the what normal, so know what is missing in here is the nasal bone. In this profile view, we will see the nasal bone clearly. So here it is missing. So what we will call it as a hypoplastic or absent nasal bone. Same thing we can confirm in the pre-maxillary triangle view, where the apex of the triangle is missing. So in profile view, nose we have seen which is abnormal. This is maxilla and vomer. They form the another dash. Here we see it is broken, it's not continuous. So we go into other face planes where we examine pre-maxillary triangle. Here is the base is missing, which is formed by the maxilla. In the same patient, when we come little bit more anteriorly, we see even the lips is broken, and even the one nostrils is not very well visualized. So this is a case of cleft lip, cleft palate. As sir said, most of the time we can pick it up in nowadays with the first trimester. Still we can get them in the second trimester also. So if these are the orbits, which is a normal orbit, I want to have an impression, visual impression, so that there is any different than previous image. Here the orbit looks subjectively small. So what I'm going to do next, because I'm seeing it as a subjectively small. So I'm going to go and measure them and going to compare with the nomogram chart. So this is normal. Comparing with the normal, they are small. So when I measured, when it is a case of microophthalmia, when I measured, they are less than 2 standard deviation for the period of gestation. So just eyeball small, whether it is going to make a difference? Yes, because common etiologies include chromosomal genetic defect, or sometimes even in the fetal infection, we will get these kind of things. So even if I'm seeing just small eyeballs, that should make it a concern. It should not be just I saw it little bit small, it's okay. So whenever we get in a conclusion, whenever we get a facial abnormality, we have to go for additional measurement into the standard planes. So we will see for the inferior facial angle, jaw index. I will not go into detail of them. These are just for the summary. So when I see the profile, I feel it is little bit something different than the normal. So what is normal? I can see the frontal bossing very nicely here. But comparing to it is little bit flat. Nasal bone is there, here also there. But this entity, we call it as a fat facial profile. But whenever I get this kind of facial profile, it should make me think, okay, what could be the etiology behind it? Sometimes it could be the familial also. But these are associated with the genetic abnormality, autoimmune disorder, warfarin embryopathy. But when I get this, I need to see for other any structural abnormality if I'm getting or not. For example, if I get an premature calcification at the femoral end, epiphysis, then it becomes a component of the chondrodysplasia punctata. And that needs to refer to the patient to the fetal medicine and genetic evaluation. So whenever we get abnormality in a system, instead of concluding in hurry, we have to see, we have to do the complete systematic examination of the field. Only flat face is not going to make a conclusion. If I send that patient to the geneticist only flat face, it will be a n number of entities we want to evaluate. But if I get a fat facial profile and a premature ossification of the epiphysis, then I know I'm looking at something skeletal. So we have to do, if one system is abnormal, still we have to evaluate the other system in detail. Coming to the thorax, these are the three planes in which we try to see the thorax. In the axial plane, we see ki ribs, they should extend 2/3 of the hemithorax bilaterally. Then we see the symmetric lung, their echogenicity. Lungs are little bit echogenic than the liver. So that how there should be, and there should not be any collection. Right lung, heart and left lung, they all occupy 1/3, 1/3, 1/3 of the thoracic cavity. If there is any disproportion in them, then there is some mediastinal shift and I have to evaluate the fetus further. So apart from this, if I'm getting anything different, whether I get a mediastinal shift, then I have to evaluate what is making it different, whether it is a lung abnormality or there is lung hypoplasia, what it is. So if I get these kind of lung, I know normal lung how they look. They look little bit echogenic, they are uniform, there is no cyst, and if I getting this, these two kind of picture, I know whether they both are same or different. These two are the different things. First, in case if we see in the left thorax, we will see the echogenic lung with the multiple cyst, and we do a color Doppler study to it, we will see the blood supplies from the pulmonary artery. So the diagnosis becomes congenital pulmonary airway malformation. But the same case, if I get the down, I see the echogenic lung, little bits of cyst, but when I see for the blood supply, it is directly from the aorta. So that makes a differential diagnosis as a pulmonary, bronchopulmonary sequestration. Those cases too both look same, but they are different, and we can differentiate them with the color Doppler study. So next case is, here we see there is a mediastinal shift, heart is shifted on the one side, small lung, and other side I am not able to see the lung only. And in the sagittal view, when I see there is a stomach which is displaced in the thoracic cavity. And if I see the blood supply, the superior mesenteric artery is going towards the thorax. So this makes me the diagnosis of the congenital diaphragmatic hernia, in which we do the additional calculation we call with OE ratio. If it is more than 45, we say the prognosis is better. And patient, whenever we see there is abnormality, patient asks me, okay, now how baby is going to do? What are our possibilities for this baby? Then we have to see, we have to, that anomaly, we have to do the severity assessment. Severity assessment, which will also give us as a prognostic markers, what are the prognostic markers, and how we are monitoring the patient. Detection and prognostication, they go hand in hand. Only detection will not conclude an anomaly scan. So coming towards heart, situs is the most important thing and the first step while evaluating the heart. So whenever a normal situs depends while calculating in which position the baby is, if it is a cephalic or whether it is a breech. So that gonna makes a difference. When it is a cephalic, the spine, stomach bubble and portal vein, they go in the clockwise direction. And whenever the baby is in the breech position, the same will go in the anti-clockwise position. So it is always recorded in the foreplane, in which the presenting part we will mention. Here in this case, the baby is in the breech position. So when it comes to the spine, stomach bubble and portal vein, they are going in the anti-clockwise direction. Same thing in this case, if we see, otherwise head is down, head looks okay, and the occiput is on the 11 o'clock position. Heart is on the same side of that of stomach, but even in the cephalic position, the stomach bubble, portal vein, they are going in the anti-clockwise direction. So this is a case of situs inversus totalis. It looks same, but it's different, and hence the diagnosis. So these are the normal section which we see in the heart, that is a 4-chamber view. Outflow tracts, left outflow tract and right outflow tract, and 3-vessel view. Coming towards the 4-chamber view, this is a B-mode image. I want everyone to have usually corrected. So what we think we do, cardiac axis is normal is 45 plus 25, so it is a subjective assessment too. Every time we did not to go and measure the cardiac axis. We see the chamber symmetry. Both chambers should be equal in the size, right and left. We see for the offset, it should be apical insertion of the tricuspid valve. We should see for the foramen flap opening, and we should see where the pulmonary arteries are draining and how is their integrity of the interventricular septum. Once I know what is the normal, so if I get these kinds of heart, I know something is abnormal. So what is abnormal? Here the chamber symmetry is there, situs is normal considering, and I see an echogenic spot, that is an echogenic intracardiac focus. It is just a marker for the trisomy per se in the heart. It won't cause any functional disability, but if the FTS is low, it can be very well taken, which Sumit will cover in his talk. If this kind of 4-chamber heart if I get, I will see there is a integrity is broken within the so I thought it is okay. So there is a integrity of the interventricular septum which is a broken. Even the septum primum is not seen. So this is a case of AVSD. So any deviation from the normal, we will pick it up once we know what is normal. So this 4-chamber, is it looking normal? Axis is right, there is a chamber symmetry also, but when we see the crux there is a more apical insertion of the tricuspid valve. And it is, so it's even the right atrium which is dilated, so it is case of Epstein's anomalies. So coming to the chamber symmetry, the above picture we can see left chambers I am able to see nicely, but what about the right ventricle? It is very small. Even in the color Doppler there is no pickup. So hypoplastic right heart. Same picture below down, I am able to see the very good right-sided chambers, but left-sided chambers they are small. Even color pickup is also not there. So it is a case of hypoplastic left heart syndrome. Coming towards the outflows, so this is a left outflow tract. Whenever I'm getting it, if from 4-chamber, if I do a cephalate sweep, I'm going to get opening of the tracts. First is the, I don't know whether I can see it. So in which we can see the, So left outflow tract, we will see the outflow tract arising from the left ventricle, and it is continuing as a aorta. And in the left-sided picture, we can see the RV, which annotations are there. So, it's not able to see only. So we will see the RV as a right ventricular, giving rise to the vessel, which is bifurcating, which is a pulmonary artery. So this is an identification. If I'm getting a vessel arising from the left outflow tract and branching, then it's a TGA, transposition. So I should know what is normal. So here if we see, there is LVOT, but we will see the breach in the continuity of the ventricle and aorta. So there is some defect, which is VSD, which is leading to the aorta is draining both the ventricles. And same in the right outflow tract, we can see, it's not able to see, the branching of the pulmonary artery, and the right pulmonary artery is looking smaller than what is normal. So it's a case of tetralogy of Fallot, where the aorta is committed to both the ventricles and with the pulmonary atresia. So normal 3-vessel view we see for the alignment, number, and sizes of the vessel. So larger is the pulmonary artery, aorta, and superior vena cava from left to right. Same thing we'll see in the 3-vessel trachea view in the color, which will be of color opposite that of inflows. This is abnormal when I see get a 3-vessel trachea view, and I get additional vessel which is arising from the base and going towards the right side. I know it is an aberrant right subclavian. Sumit will cover it in his talk. So this is a case as a whole where I can see the normal 4-chamber where they are symmetrical, normal inflows. But when I come to the 3-vessel trachea view, I'll see the abnormal, that is a I sign. And when I try to open the outflows, then I see the parallel outflows. So this is abnormal. Diagnosis is TGA. Coming towards abdomen, so these are the sections which see in the abdomen, the axial section from upper abdomen to the lower abdomen. We see for the stomach, which is a AC section we all are familiar with, and same section we will see if we go down little bit, we will see for the renal pelvis, and where we can take the measurement. Going down, we will see the cord insertion site, and putting color Doppler, we will see the umbilical vessel is 3-vessel view. And if we go further and we try to evaluate, we will able to see the penile muscular plex. If I know what is normal, so here, I know what is abnormal here. So when I see the cord insertion, we will see for the integrity of the anterior abdominal wall. Here I'm not able to do it. So here the integrity is broken. I see the small bowel protruding into the abdomen, amniotic cavity. So it is a case of gastroschisis. But same thing if I see with the membrane and there is some liver popping out in the left side image, it is a case of omphalocele. Both things, their genetic association is different. Omphalocele is more associated with the genetic abnormalities and need an evaluation. So, and the third lower picture is for the kidneys, where we can see the one pelvis is dilated and the other is small. After axial plane, we will see abdomen into the coronal planes. These are the standard plane which we see and document. First is the stomach bladder, in which the small bowel little bit echogenic. I can see the diaphragm also, so it's a normal stomach, bladder stomach section. The same section I've give little bit posteriorly, I will see the bowel, which I will be more seeing into the late second trimester onwards, 24 weeks onwards, and in third trimester. And given further posteriorly, I will get the coronal kidneys. So if I get these kind of picture, the bladder is distended, the kidneys in the left side images, all the cystic structures are the both kidneys dilated with the yellow arrow pointing towards the dilated ureter. So my diagnosis once I know what is normal, I will not be seeing ureter normally on the anomaly scan. If I am seeing them, they have to be dilated. Same thing if I see the renal pelvis is dilated, both the dilated, then I'm going to go do a measurement. I'm going to see the bladder. Bladder is also dilated. They will give me diagnosis towards the lower urinary tract obstruction. So we can conclude in certain abnormalities what will be the cause, but not always. If the same coronal section in the first picture on the right side, the yellow arrow is pointing down towards the adrenals, but I can see only the upper side kidney and the lower side kidney I'm not able to see. To confirm, I will put a color Doppler and see for the renal arteries, but renal arteries are not visualized on the same side. Even I try to see in the axial plane. Whatever abnormality we are getting in one plane, we should be able to consistently get in other planes also. So even in the axial plane, I am not able to see the kidneys, and instead of this, again, I am able to see adrenal only. So it's a renal agenesis, or it could be the ectopic kidneys also. So when I see these both, not dilated, but both cystic kidneys with the irregular cyst and large, so my diagnosis changes from the lower urinary tract obstruction to the multicystic dysplastic kidneys. So same thing if I get, kidneys are normal in side shape, but they are looking little bit white. These are echogenic kidneys, and they need follow-up and evaluation further, and we have to see, assess, whenever we get a renal abnormality, Liker has to be seen first. And even when we see the dilated bowel loops in the second trimester, they are most likely the small bowel, not the large bowel. Large bowel we see in the third trimester. Coming to the extremities, whenever documenting extremities, we see them in the all three segments must be seen, documented clearly, and only we routinely measure the femur length and humerus, but if we are getting the discrepancy, we have to see for the others, bone measurement also is needed. So whenever foot and lower limb, they are always 90 degrees to each other. If I know this and I am seeing this picture, I know I am looking towards an abnormal lower limb. So it is a case of CTV. But when I get the short femur which is bent, it's not with the femur at a fault. We see also head which is head also which is like hypomineralized. I see along with that a narrow thoracic cavity, short ribs. So it's not a simple femur which is short, but it is a case of skeletal dysplasia. So whenever we come across a short femur in the second trimester, first we have to check for the dates, whether it's a constitutional, if everyone in the family is small, and whether it is a evolving fetal growth restriction, or it is related with the aneuploidies, trisomies, or it is a skeletal. So in nutshell, whenever we suspect the fetal anomalies, we need an extended examination, and we have to separate between the normal variant so that it will reduce the patient's anxiety, and we have to rule out the anomalies. Some anomalies, they might be treatable, so they need a follow-up, and some are they are lethal, they may have a poor prognosis, and many of them are going to need a genetic testing. Not all, but many of them are going to need it, and so they need a proper genetic counseling, and it's going to be a teamwork. If I'm getting some renal abnormality, if I'm going to get a moderate pelvic tasis and all, the pediatric nephrology reference should be done. So it is going to be a team approach. The approach towards anomalies won't stop with the scan itself. It needs a multidisciplinary coordination. The patient, even with the cardiac anomalies, we need to involve a pediatric cardiologist. We need a genetic evaluation, because the anomaly is not for the pregnancy, that for the family we have to see for the future pregnancy also, and planning start there and there itself. Thank you very much. This is our book from which I have taken all the images, and the credit goes to my mentor, Indrani Suresh. Thank you.
Thank you, ma'am, for that thorough presentation. Now the topic is open for discussion. If there are any questions uh, for the chairpersons and the audience. Any questions? Thank you. So now I thank you, ma'am, and I request our chairperson, Dr. Archana Shah, ma'am, to felicitate our speakers.
It's very common to get echogenic intracardiac. Single echogenic intracardiac focus and where it is located is also important. If it is in the LV, single intracardiac focus is there. If we have done the first trimester screening and it is a low risk, we don't need to be anxious for the single echogenic intracardiac focus. But if I see them in the interventricular septum, if I'm seeing a multiple calcification, along with the echogenic focus, even in the other organs, then that it will be point out over the infection and all, and other things. But single echogenic intracardiac focus in LV, otherwise fetus is normal, FTS is low risk, we need not to put ourselves and patient at a panic. So it has a very less likelihood, 0.9 likelihood ratio. So it is mainly for the soft marker for the aneuploidies, and rather than it won't affect a cardiac function per se. Then we can ask patient for the, if there is a cardiac anomaly in the family. So we need to know what kind of it is, whether it is associated with the genetic or evaluation has been done. If it is done, we can ask. Even in the patient who has the previous baby with the heart disease, we will ask this pregnancy also, we will ask patient an echocardiography at 22 to 23 weeks to rule out evolving anomalies. And even if anomalies can normal, so we should be, even patients should be aware of, there would be the evolving anomalies which cannot be picked up, every anomaly cannot be picked up. Evolving, even heart looks normal, everything, but over the period patient develops some atresia or even coarctation of aorta, which can be missed common. So these are things which will get evolved. Even CDH can evolve later in the third trimester. So patients should be aware of evolving anomalies also.
Thank you, ma'am.
Hello. Hello. Yes. Okay.
Thank you, ma'am. It's double the giggles and double the grins and double the trouble if you are blessed with twins. Our next topic for this session is dealing with twins by Dr. Shweta Gugle. I request ma'am to come on the stage. Dr. Shweta Gugle is MBBS MS DNB OBGY. She has done a fellowship in fetal medicine at Mediscan Chennai, currently as a consultant at KM Hospital Pune and Pune Fetal Care Center. Her interests are mainly in multifetal gestations, first trimester imaging and fetal interventions.
Double window. Display setting window. Right. Display setting. Display. Double.
Okay, good morning, everybody. Thank you all for having us over. And I also like to thank for such a warm welcome we had yesterday. So I would start with a question actually. So how many people can you see in this slide? Any answers? Not to our team. 5. Okay. So, ma'am, can you please explain me? Yeah, two are in scrub. Yeah, actually there are 4. So 2 is in the scrub, 1 is the patient, and the tiny one which is yet to come into life is the fetus. So only in past few decades, the fetus has been considered as a patient and has become an subject of extensive research. So today my topic is, as she said, double trouble or double happiness. So I'm going to talk about dealing with multiple gestation. So there is no diagnosis of twins. They are either monochorionic or dichorionic. You're not, after the end of this lecture, you're not going to call them as twins. You're going to call them monochorionic twin or dichorionic twin, because the whole management of the twins depend on the sharing or non-sharing of the placenta. So I'm going to talk about how to identify the chorionicity, dating, first trimester screening in twin pregnancy, and twin-specific problems. So chorionicity is best determined in the NT scan, that is at 11 to 13 weeks of gestation. So the image of chorionicity has to be preserved, because if the patient goes elsewhere and in mid-trimester, there will be again a question mark that it is going to be a dichorionic or monochorionic. So the first trimester images has to be preserved with the patient. So if it is not possible for the first operator to demonstrate the chorionicity, you should sort for the second opinion to a tertiary referral center. Whenever the chorionicity is in doubt, you should always treat them as monochorionic twin. Now, how to identify the chorionicity? So in early gestation, so in early gestation, you're going to have 2 sacs, 2 yolk sacs, and 2 fetal pole. Around 12 to 13 weeks, you can see this lambda sign, which is a projection of chorionic tissue in between the membrane. So whenever you see this lambda sign, you know that it is dichorionic, diamniotic pregnancy. Other useful thing is that they'll always have 2 different placenta, either anterior, posterior, or even if they are lying on the same side, there will always be some furrow in between. Coming to monochorionic pregnancy, here you will see a single gestational sac, 2 yolk sacs, and 2 fetal pole. Now when the pregnancy advances at 11 to 13 weeks, you are going to see this T sign. Here you will not see the projection of chorionic tissue in between the membranes. So there's a thin membrane, so that gives you the diagnosis of monochorionic diamniotic twin. Then this is the monochorionic, monoamniotic, the most dangerous one. Here you will see the single placenta, 2 fetuses. These 2 fetuses don't have a membrane between them. They are always lying close to each other. Their cord insertions are also close to each other. They have a common finding in later in gestation of cord entanglement. So how will you identify this? Whenever you are scanning a patient, and if you tell the patient to roll on any side, you'll always see that these 2 fetus, due to absence of membrane, they are always lying together, close together. So you know that this is a monochorionic, monoamniotic twins. So coming to the dating, now multiple pregnancy are at increased risk of growth restriction, and that is why the dating is very important for them. So how will you date the twin pregnancy? First, when the lady comes, you're going to ask them whether it is the assisted reproduction or whether it is natural. If she says it is assisted, it becomes easier. You assign the date only by embryo transfer date. When it is a natural pregnancy, then you assign by LMP. Now, when she comes to you at NT scan, you see the CRL. If the CRL between the two twins is different, that is more than 10 mm, or the discrepancy is more than 14%, then you assign the date by using the larger CRL. If she comes late to you after 14 weeks, then you assign by the head circumference of the larger twin. Now coming to the aneuploidy screening, only first trimester screening is advisable for twin pregnancy. So you do NT-NB, which is very, very important in twin pregnancy, and then you combine it with double marker. Now why NT-NB is important? Because whenever it is DCDA twin, you get the risk as per the NT-NB of two twins, and you will get two risks in DCDA pregnancy. But in MCDA pregnancy, you will get a single risk. So NT of each baby is very important in case of monochorionic twin. So if you see at the outcomes here, you will see that the highest number of complications is in the monochorionic twins. Now when your ultrasound surveillance for dichorionic is almost same as singleton, but you will include fetal Dopplers from 24 weeks onwards. But in MCDA, the protocol is very much different. At 16 weeks, the most important thing is the single deepest pocket, placenta and the cord insertion, anatomy of course, and we start including the Dopplers at 16 weeks. So umbilical artery and ductus venosus Dopplers help us in prediction whether they are going to land up in complications. 18 weeks we do the echocardiography, and we do 2 weekly evaluation for MCDA pregnancy. Why, you will come to know in the subsequent slides. So if it is uncomplicated twin, DCDA can be delivered at 37 weeks and MCDA can be delivered at 36 weeks. Now what are the complications in MCDA? So the discordancy, matlab difference in both the twins is very, very important. So first is the CRL discordancy. In the NT scan, if you see one CRL big, other CRL small, you will gear up your guns to monitor the pregnancy, because this pregnancy might lead in selective growth restriction of one fetus. Second is the NT discordance. If NT of one fetus is more, the other is less, they may land up in TTTS. The most important is ductus venosus, and the sensitivity or predictivity of the ductus venosus is more for TTTS. If you see a A-wave reversal, that will prompt you to have a closer surveillance for the baby for development of TTTS. Now, if the twins are discordant for anomalies, what are you going to do? You have to classify first whether the anomaly is lethal or non-lethal. Now, lethal anomalies like anencephaly or bilateral renal agenesis, you know that the baby is going to die, so why should we intervene? You have to intervene if there is going to be polyhydramnios that will cause the other baby at risk, or if it is going to cause IUFD in the other baby in case of monochorionicity. So how will you interfere? Either you are going to do reduction, selective reduction. If it is a non-lethal anomaly, here is a problem, because you know that the babies are going to survive. So when should you interfere? Now you should interfere, you have to balance whether the baby which is going to have a non-lethal anomaly will have future handicapness versus the interference risk which might lead to preterm delivery. So you'll come to know in subsequent slides now. So counseling at this stage is very, very important, and that should include a fetal medicine team. So in MCDA, the selective reduction can be done by bipolar cord occlusion and radiofrequency ablation. In DCDA, the reduction can be done by intracardiac KCL. Now in the first video, we are doing the bipolar cord occlusion for MCDA pregnancy. So this is the bipolar forceps we are using, and this is the cord we have, trapped in the bipolar, and we are going to coagulate the cord. In the second video, we are using radio frequency ablation needle. So here this needle we introduce into the fetus, and it has tines, and these tines release heat energy which causes coagulation in the baby. So these are the two methods which we use for the MCDA twins. Now, in your first 16-week scan, if you see a Leica discordancy, what you should suspect? You should suspect either they're going to, progress towards some abnormality of anomaly or growth, or they might develop TTTS. There can be leak, or so you have to call the patient within 1 week to see whether they are progressing towards TTTS. So in twin pregnancy, you have to measure only the single deepest pocket and not the AFI. Now coming to the complications specific to MCDA pregnancy. First is TTTS. Now what is TTTS? TTTS is twin-to-twin transfusion, where there is imbalance exchange between the twins. One is the donor and other is the recipient. So due to these AV anastomosis, big AV anastomosis, there is flow from the donor to recipient. So recipient gets lot of blood and the donor is deprived of blood. So one becomes overload on heart and the other has IUGR complications. So there is staging of twin-to-twin transfusion. We'll not go into detail of this. So we will now discuss a case. Now this lady had come to us with absent kidney. She was referred to us twins with absent kidney. So at 19 weeks, we did a scan. So there was Leica in one side was 1.8 and other side was 7.2. So due to 1.8, the primary operator could not see the kidneys. But actually it was a case of MCDA with oligopoly sequence, oligo and poly. This is not exactly poly, but a high Leica. So now we had a close surveillance for this. We called her at 20 weeks. And within 1 week, she progressed to TTTS stage 3. Then we planned for fetoscopic laser ablation. So here we are introducing a fetoscope, which is 3 mm, into the uterus. Then we mapped the placental anastomosis. And then we ablate the anastomosis. So in this, what we do, the monochorionic placenta is converted into dichorionic placenta. So each baby has an individual blood supply. So this was post laser. The first day, you can see now the Leica is coming in the donor area. We could see the bladder, the cardiac was recovering. At 23 weeks, the cardiac status was much better than before. We followed this pregnancy till 34 weeks. Finally, we delivered her at 35 weeks LSCS, and both the babies are doing well. They are now 2-year-old, 2.2 kg and 2 kg was the birth weight. So if we don't intervene the TTTS, you might end up losing the pregnancy because eventually the babies are going to die. So this is one chance we are going to give them to, survive. Next is SIUGR. SIUGR occurs when there is unequal placental sharing, which leads to suboptimal growth in one twin. So whenever the effective weight of the other twin is less than 10 centile, or the discordance is more than 25th centile, we call them as SIUGR. So this is the classification of SIUGR, type 1, 2, and 3. Now in type 1, there is a forward flow in umbilical artery. And these are the cases where we don't intervene, we just follow them up. Type 2 and type 3, you need to intervene them because the other fetus is at risk. So this is a case of type 2 SIUGR, where one fetus was IUGR and the other was growing normally. So you can see this is the AC of one and the AC of other. And in the umbilical, there was absent diastolic flow. This is SIGR type 2. So we opted for RFA. In RFA, you will compromise one fetus so that the other fetus is growing. So this is the RFA needle, which we put into the abdomen close to the cord insertion. And we release the tines and the heat energy is produced that will cause coagulation of the blood flow. So this pregnancy was followed up till 38 weeks because now it was a singleton and it was delivered at vaginally, normal delivery, 3.2 kg baby weight. The baby is doing well now. So this is the RFA needle. Third complication is TAPS. TAPS means twins anemia polycythemia sequence, where one baby is anemic and the other is polycythemic. So you can see this baby is red, that is polycythemic baby, and this is pale, this is an anemic baby. So this is diagnosed only by MCA Doppler. When you look at the placenta, there's a thin translucent placenta which is of anemic baby, and this is a large hydropic placenta which is of polycythemic baby. So how do you manage TAPS? We can just follow it up closely, or we do intrauterine transfusion into the umbilical artery or the portal vein, or we can do intrauterine transfusion with partial exchange for the polycythemic twin, or we can also use fetoscopic laser ablation. Then the last complication is TRAP sequence. Now it occurs mostly in monochorionic pregnancy, where the normal pump twin and the other is the acardiac twin. Now what happens if we continue this pregnancy? This acardiac twin is going to pull all the blood from the normal twin, causing danger to the normal twin. So we do intervene in this pregnancy where we use radiofrequency ablation. So this is the radiofrequency needle we are using and into the trap baby, and we'll ablate this baby's cord connection. So the other baby continues to grow well. So when you need to refer the twins, whenever they are MCDA twins, because they need close monitoring, whenever you see a discordancy in NT and CRL, whenever there is discordancy in weight, whenever there is a suspicion of oligopoly sequence, because that is the start of all the abnormalities in MCDA twins, whenever there are higher order gestations like triplets or quadruplets. So what have we seen till now? Now all sort of fetal therapies are available in our country, but proper treatment is not always intervention. Like in SIGR1, you don't need to intervene. So fetal surgery also has its limitation. So we need to choose the case carefully, and we should know when not to operate. So first thing in fetal medicine is do no harm. So this is our twin fetal therapy unit, which we have recently started. So this is a small video of our unit inaugurated by Dr. Suresh. So we'll also be having funding so that we can help the poor patients. This is the OT room, which will be fully, we have the laparoscopic unit for fetoscopy, radiofrequency ablation. So up till now, we have done 4 fetoscopic laser ablations, radiofrequency ablation, and thankfully all the babies are doing well. My special thanks, I would like to end Suresh, Dr. Manikandan sir, and thank you all for very patient listening. Any questions, you're welcome. Also,
thank you, ma'am, for that remarkable presentation. Now the topic is open for discussion. Any questions from the chairperson or the audience?
So in this conference recently, we launched this book of Essentials of Fetal Medicine. It is actually a very, go through it. Thank you.
I request Dr. Vinod Chete sir and Dr. Archana Shah ma'am to kindly felicitate Dr. Google ma'am. double. I request Dr. Kachre sir and Dr. Deshmukh sir to kindly felicitate our chairpersons for this session, Dr. Archana Shah ma'am and Dr. Vinod Shetty sir.
Let's move on to the next lecture on genetics in fetal medicine by Dr. Chaitanya Datar sir. I request Dr. P.B. Mohite sir, please come on the stage to chair the session. He is a senior obstetrician and gynecologist working since 30 years in Pandharpur. He is a past president of Pandharpur OBGY Society. He is consultant at Mohite Hospital, Pandharpur. I request Dr. Anand Bhinge sir, please come on the stage to chair the session. He is a senior pathologist. He did his MBBS from D.Y. Patil College and post-graduation from Krishna Institutes. He has his own Siddhivinayak lab and also work with Sarjubai Blood Bank, Pandharpur. I request Dr. Neeraj Shah sir, please come on the stage to chair the session. He is a well-known pediatrician. He has done MBBS from Krishna Institute, Karhad, and MD pediatrician from Praura. Brief introduction about Dr. Chaitanya Datar sir. He is a consultant clinical genetics, director of Sujan Clinics and KM Hospital, Pune. He has 15 years of experience in his field. He is in charge of fellowship program in genetics metabolics at Bharti Hospital.
Good afternoon. At the outset, let me thank the Pandharpur OBGY Society, Dr. Sudesh Doshi, Dr. Kane, and for having us here. My topic is genetics in fetal medicine. So what I'll delve with today is essentially looking at what all tests do we perform in an ongoing pregnancy, then various case scenarios in genetics where genetic evaluation is necessary, either based on history, previously affected cases, high-risk cases, etc. Then we'll have some cases which are amenable to therapy or management in the antenatal setting from a metabolic perspective, and very importantly, psychosocial implications of these results and necessity for genetic counseling in pregnancy. My first slide is always the basic, do these 46 chromosomes really constitute all our genetics? So answer is yes and no as well, because essentially if you open up the chromosome, it's going to be a long thread of coiled and supercoiled DNA. So essentially if you're looking at a gross chromosome as such, we are dealing with chromosomal disorders which are picked up on a karyotype, and you're picking up Down syndrome and Edwards syndrome and Turner on that. Then if you're looking at chromosomal segments, that is when I'm doing a microarray, I'm looking at deletions and duplications. And when I'm going to the rung of the ladder, that is the ATGC bases, there I'm doing a monogenic evaluation, that is by either a Sanger sequencing or an exome-based sequencing. So essentially, you can equate it to a books on a bookshelf. When I'm looking at the books from outside and keeping it back, that's a karyotype. When I'm looking at the segments of the book, that is a microarray. When I'm looking at reading each page letter by letter, that's when I'm doing an exome sequencing. So now we have a lot of new tests which are now available. We have arrays and NIPS and exomes. So what is the exact utility? Are the older tests obsolete or not? Okay, so what we just briefly discussed is based on biochemistry, various soft markers, anomalies, how to plan invasive testing, and how to interpret results. So as Dr. Shripad mentioned in the morning, Down syndrome should be a universal screening. The reason being, all of us have 46 chromosomes. Obviously, each partner would contribute only 23 chromosomes. So 23 from the husband, 23 from the wife will give rise to a cell with 46 or an embryo with 46, giving rise to the entire baby. But what happens in aneuploidies is, instead of the equal division, the division is unequal. One of the partner contributes 24, the other partner contributes 23, giving rise to a cell with 47. So as a result of which, essentially, the baby comes to have Down syndrome. So usually age is no bar. We rather see more Down syndrome babies born to younger mothers than the older mothers, because older mothers are usually screened, younger mothers miss screening, and as a result, we see more Down syndrome babies born to younger ladies. Always try, when we are screening, it should be a scan, the sonography findings along with the biochemistry, that is NT scan, combining with the double marker test. So this was elaborated in the morning, so which is the best screening technology, possibly the first trimester screening, that is NT scan, along with the double marker test, gives an accuracy or pickup rate of almost 85 to 90% for Down syndrome, while triple test is usually now obsolete, ideal not to use it. Quadruple marker gives an accuracy of 75%. So if you have missed your first trimester screening, you can go for your quadruple marker to screen for Down syndrome. Obviously, you can have integrated screening as serum integrated screening as well. But if you have done a good first trimester screening, usually the other things are not required. Why is screening done? It's mainly for Down syndrome. So that is one thing that we must clarify always. It's only for Down syndrome. But also at the same time, it gives us risks for open neural tube defect, risks for trisomy 18, 13, Turner. And nowadays, based on various other markers like PAPE, PLGF, etc., we are looking for SGA babies or preeclampsia and preterm delivery risks also. So essentially what you should look at in your marker report is the MOM values. You don't look at the absolute values, you look at the MOM values, MOM values, so which are in numbers. So for example, if you have a MOM value of 0.5, at what we expect that 33.45 is a 1 MOM for that given gestation. So if the value is 15, it is going to be half MOM. If the value is 63, it's going to be 2 MOMs. So MOM values being increased or decreased is what we need to look at. So now we'll take a case wherein it's a 23-year-old primigravida, and otherwise a low risk, NT is quite good. So what we are seeing, the MOM values are 0.87, 0.92 for beta HCG and NT, and 1.31 for PAPE, so which is fairly close to 1. So anything which is close to 1 is fine, and the risk is 1 in 28,000. So when we are saying the risk of 1 in 28,000, it's a low risk for Down syndrome, that is 85 to 90% you have ruled out Down syndrome. But what is very crucial is you're looking at the marker trends. Very low PAPE, below 0.2, raised beta HCG, which is 2 to 3 MOMs, or a low UE3 below 0.2 MOM should alert you that this could have some genetic issue as such, either chromosomal or single gene. I've marked those two markers, PAPE and UE3, because they're sensitive markers even for certain single gene conditions. So if you have a normal trend of markers, otherwise only just the age risk which is responsible for the high risk, in that case you can always opt to consider an NIPS or with proper counseling, or also give them the option of invasive. But if you find the trend abnormal, in that case you should give the invasive testing as possibly the first priority over NIPS. So looking at the MOM trends always helps us in selecting whether we should do an NIPS or we should go for an invasive testing. So in this case, what we see, the PAPE is very low, 0.26. The beta HCG is 2.90. The trend is adverse, and that has given rise to a risk of 1 in 90. So this lady has had already 3 first trimester miscarriages. NT is fairly normal. So now, whether we choose NIPS or we go for an invasive, so usually for intermediate risk, low age risk, if there's no bad obstetric history, NT is normal, those are the cases wherein you can always go for an NIPS. But if it's a high risk, greater than 1 in 100, advanced age, previous bad obstetric history which has not been evaluated, ART pregnancies, this possibly you can opt for an invasive testing. Also, if the marker trends, as I mentioned in the earlier slides, are abnormal, you should put the invasive testing as a first priority. Now in this case, an invasive was done and it turned out to be Down syndrome. So the other aspect is prenatal soft markers and anomalies which you come across, and how do we evaluate them? So deeper analysis is usually helpful if you are, and possibly safer to offer as an option in case we are dealing with anomalies or soft markers. So always we can consider rapid aneuploidy screen, that is the FISH or a QFPCR as first line, and second line you are going to offer a karyotype or microarray depending on the marker. Now, in this case, the NT is 5 mm, okay, and the mom is almost 4.7, and you can see the adverse markers. The beta HCG is 0.26, PAPA is only 0.14. So this is not a very reassuring double marker report, and the risk has come out to be 1 in 26. So as Dr. Shripad mentioned in the morning, raised NT is not equal to Down syndrome. Down or Turner syndrome may be noted in only about 50 to 60% cases, but non-aneuploidy related single structural defects may be noted in 10 to 15%. So these fetuses need to be screened properly during pregnancy for any structural abnormality, but we must be alerted to the single gene syndromes, especially Noonan syndrome, which is fairly common and would be noted in about 5% of cases. There could be single gene abnormalities. So here NIPT should not be the test of choice, and invasive testing was offered, microarray was normal, but again the things worsened further and there was hydrops and the fetus was discontinued. And if you look at the fetal image there, it is a hydropic fetus, and which later we investigated, it turned out to be a MPS type 1, that is Hurler syndrome. So always we have to be alert when we are having a raised NT, and there could be a possibility that we are dealing with a single gene condition as well. So this counseling is very, very crucial during pregnancy. Now, what is the test of choice for soft markers that we come across? So if it's a raised NT, obviously we are offering a FISH QFPCR as first line. Microarray and molecular evaluation for Noonan syndrome should be considered for these cases. Hypoplastic nasal bone, I'll show you one case. You do a FISH, but microarray may be a preferred test here in this case. Further going down, cardiac anomalies, we are evaluating for FISH if it's one of the conotruncal defects, possibly for 22q microdeletion, and you can perform a microarray. If it's echogenic bowel, so along with your chromosomes, you have to evaluate for conditions like cystic fibrosis, congenital adrenal hyperplasia, brain anomalies, possibly go for a microarray and then wait for evolution. And growth restriction, you can offer a FISH along with a microarray. So each case has to be, really, you cannot have a generalized approach as such, and you have to customize each test for each of the patients depending on the various history. Now in this case, essentially what I'd mentioned earlier, she had a very low PAPA. A PAPA was 0.21, beta HCG was 0.71. And later it showed at 16 weeks there was absent nasal bone on one side and the other side was hypoplastic. If you would have done a karyotype, it would have turned out to be normal. We did a microarray and it was a 17q to 1.3 microdeletion. Now this it is a syndrome which is called as a Cullen-de-Vries syndrome, which postnatally can give rise to developmental delays, epilepsy, seizures, hypotonia in almost 90 to 100% cases. So here the finding antenatally was only a hypoplastic nasal bone, but if you don't properly investigate, you may land up with babies being born with these conditions. So we have to be very alert when we are counseling the patient, and always offer, put it on paper, especially medico-legally it becomes helpful that we are offered the test. Whether patient chooses or not is his or her own choice. Now if it's a elderly lady, 38-year-old lady, it's a very precious pregnancy after prolonged infertility period. NT scan is normal, and what we are seeing is an intermediate risk of 1 in 660 for Down syndrome. And for trisomy 18-13, it is low risk. Obviously, we can give them the choice. If the risk here any time is less than 1 in 1,000, she can just continue as a routine. If it is more than 1 in 100, preferably you should offer an invasive testing, but for intermediate risks between 1 in 100 to 1 in 1,000, again you can give them the option of NIPS, integrated quad, or an invasive testing. So essentially, what is non-invasive prenatal screening or NIPS? It's going to pick up the cell-free fetal DNA from the maternal blood. One very important aspect is a fetal fraction that we must look at. So any fetal fraction should be beyond 3.5 or 4% for the report to be interpretable. If the FF is less than that, the report may not be interpretable, and you can get a false positive or negative values. So suppose you have an NIPS which is screen positive, do you directly act on that report? Here the risk for trisomy 21 is more than 1 in 20. It should be followed up by an invasive testing which has confirmed Down syndrome in this particular case. While in this particular case, it's a 30-year-old, 13 weeks pregnancy with a normal ultrasound, and the risk for trisomy 13 is high. So what we know is that the cells which are released into the maternal stream are from the placenta, and placenta can be a mosaic. So sometimes for trisomy 13, 18, that can be an issue. If you do, now in this case, an invasive testing was done, the fetus was normal. So never consider discontinuation of pregnancy based on NIPS results. You have to look at, if you can see that below that, it is something called positive predictive value for each of the trisomies. So PPV for this particular condition is 70%. That is, if you get a screen positive result, 70% of the times your invasive will come out to be normal, but 30% of the times the fetus will be normal. So you have to look at all these parameters when we are looking into the report. So what are the general indications to do an NIPS? Guidelines do suggest that it is only a screening test for Down syndrome, and you can do the other common aneuploidies, but nowadays some expanded panels are available, the option you can offer to the patient, but as of now we do not have enough studies to really validate the findings, but it's an individual choice. You can offer that to any patients who wants to do it, especially those who have only maternal age-related risks beyond 37, etc. Twin pregnancies as a screening tool, it's more efficient, proven than the conventional first trimester screening. Screen positive results on your routine first trimester test wherein they're not wanting to do an invasive, so with proper counseling they can do that. If it's a precious pregnancy, they can opt for this. When it is not a test of choice, this is also very important. If there are any fetal anomalies or soft markers on ultrasound, NIPS should not be a test of choice. It would be more of an invasive test. Known genetic abnormalities which are not picked up on NIPS. I've seen NIPS for beta thalassemia also being written. So DMD, thalassemia, these are all single gene conditions which NIPS is not going to pick up at this moment. So known maternal aneuploidy. Now some of the ladies with, we have some mosaic monosomy X with, triple X ladies conceiving. Now if you know that that lady has had and she has had a donor, embryo transfer or donor egg taken. Now that lady you can't consider for testing because she's aneuploid herself. So your results are going to be skewed. So you have to be careful. It should be noted that the couple karyotype should be normal when you're doing an NIPT. Usually post-malignancy, post-transplant patients, you cannot do this. For multiple pregnancies, triplets and beyond you cannot do, but for vanishing twins, you can collect the sample after 8 weeks after the twin has vanished or having been reduced. It cannot predict late pregnancy complications, etc. Now, sometimes you come across some unexpected outcomes. Everything was going fine, but suddenly you're going to get something like this. When it's a consanguineous marriage, when the antenatal scan showed high drops, along with retrognathia, choroid plexus cysts, and so on and so forth, pregnancy was discontinued. Now, in this case, what is one very important aspect is even if it is discontinued, we should try to get answers as much as possible, because in this case, this is a case of TRP11 related mutation. It's a likely pathogenic mutation causing achondrogenesis type 1A. Now, this case was thoroughly worked up. I did the autopsy, did the skeletal evaluation and the exome evaluation, and that proved this is a recessive condition. Risk of recurrence is going to be 25%. So if you want to prevent this in the next pregnancy or recurrence, we can offer an early prenatal or preconceptional testing. And this case highlights possibly why autopsy is very, very crucial. In this case, the thing is not seen, but USG showed oligoamnios, lower growth centiles, hydronephrotic kidneys, over-distended bladder. So it was suspected to do PUV, and it was considered for discontinuation along with a CTEV. Now, genetic testing was done, and that showed a compound heterozygous, which was later proven by parental studies, and pertained to Fraser syndrome. Now, Fraser syndrome is nowhere close to what the presentation was. Now, when you look at the fetus, if you look at the fetus, you can see there is hypertaylorism, and this is what is called cryptophthalmos. There is no, the eyeballs which are were completely absent. And if you look at the dermatoglyphics, there's a partial syndactyly with brachydactyly. So if you and you can see obviously the distended abdomen. So this is also associated with growth restriction as well. So this was possibly a dual pathology. The main thing was possibly which came to our notice was the aspect related to the bladder, which was possibly a LUTO, but the issue which was more important is Fraser syndrome, because that has a high recurrence risk in next pregnancy, almost 25%. So what is important is autopsy gives us at least 15-20% more information than a baseline karyotype. So any abnormal, anomalous fetuses, try to consider an autopsy and DNA storage at the minimum, which helps us in further counseling the patients. But sometimes what happens, the patients have to continue the pregnancy for certain reasons if the gestation has gone beyond. Like in this case, this lady had a previous child with almost similar affections. She landed up with a second pregnancy with a subdural hygroma, pleural effusion, subcutaneous edema. Obviously at that point in time, poor prognosis was explained. This was a little earlier before the MTP Act changed, and she had to continue the pregnancy, and she delivered spontaneously, and there was, the baby died in some hours. But here what was crucial is to take photographs of the baby. Now sometimes what happens, just taking photographs, this is called visual autopsy, that helps us in correlating the genetic results, which we confirmed to be a PINA-Shocker or fetal akinesia deformation sequence. So how do you collect and preserve samples in these cases? So essentially, if for anomalies these fetuses are terminated, you collect the samples for genetic testing. It can just be a small piece of cord, about 5-6 centimeters of cord. You just dip it in saline, put some gentamicin, and that you can store DNA. You can, if blood is possible by cardiosynthesis or chordosynthesis, you can collect that. If CVS or AF is allowed, you could do that. Placenta can be sent separately for histopathology. In actual fetus, you add 10% formalin. If you want to do a brain biopsy, you add 20% formalin through the anterior and posterior fontanelle to preserve the brain. So this is how you usually collect the samples, and that is going to go a long way in helping these patients. Now to the next aspect of invasive testing. You have to plan some certain tests by invasive testing. So one of the commonest scenarios is thalassemias, which we should discuss ideally. Then pregnancy, which presents with certain soft markers or anomalies. Those are the patients who are subjected to invasive. There's some positive family history, which is for which we would want to consider further evaluation, or fetuses and children born with abnormalities with diagnosed mutation. There was some previous child who was diagnosed with a mutation and you want to offer prenatal. So what we must understand here, the test should be again customized, and it will depend on the abnormality which was noted in that case. Pitfalls is what we must understand, and the aspect is post-test counseling, pre and post-test counseling. So what we must understand, the difference between what is a procedure and test. So if I'm doing a venipuncture, that's a procedure. Okay, and a test is hemogram thyroid. So similarly, amniocentesis and CVS are procedures. Test would be, you want to do a karyotype, you can do a fish. So you can't say send for amniocentesis. Amniocentesis is a procedure. We have to define the tests that need to be carried out on the fetal sample. So essentially there are two kinds. One is a cytogenetic test or cytogenomic test, which is your rapid test like FISH, QFPCR, FISH, chromosomal analysis, and microarray. While if you're doing a PCR-based test, you're doing a Sanger sequencing, exome sequencing. These are molecular tests. Now for thalassemia, it's one of the commonest genetic conditions that we come across. So screening should be done for both partners. So ideally, each lady who comes to the clinic must be screened by a simple screening test called HbHPLC, because the thalassemia carrier rate in some of the population is as high as 30% in some of the populations in Maharashtra. So essentially what you do is screen the lady. If the lady is positive, you're screening the husband. And if both are positive, then we have to do the mutation study. So that's how it goes in a stepwise manner. So even if the lady comes in pregnancy, this gene is a very small gene. And the common mutations, if you study, that account for almost 90% of the mutations. So even if the lady comes at around 8-9 weeks, you do your thalassemia, still we are well in time, even for a CVS sometimes, or an amniocentesis to offer a good prenatal testing. So if both the partners are screened positive for HPLC, there we are going to do a mutation studies for both, and we are going to discuss a risk of recurrence of transmission of 25%. And this is not detected by NIPS. The tests which are performed on the amniotic fluid sample is something called rapid aneuploidy testing, which involve FISH or a QFPCR. Now, usually if it's an increased risk for common chromosomes, like for example, you have a high NT, I'll need about 5 minutes maximum. High NT, or there's an adjunct to chromosomal testing. You are doing the chromosome, but you want a quicker result. That's when you're going to do the rapid aneuploidy testing. Sometimes in resource limited situations, you can just do a FISH alone, but it gives very limited information. Karyotype is generally a test of choice, but it requires culture, a longer time for results, and it is only going to look at gross chromosomal abnormalities. It's not going to look at deeper segments. So generally, a microarray may be a preferred test in these cases, wherein it is going to go a bit deeper and look at chromosomal segments. So microarray gives at least about 15-20% more information than a karyotype. Like for example, In this case, the older child was diagnosed with a chromosomal aberration. This is a case of 1p36 microdeletion syndrome. So obviously to detect this in the next pregnancy, I can't do a karyotype because it is a subchromosomal abnormality. So here you have to utilize a microarray. And further on, problem with this slide. Now, in this case, it was a 37-year-old primate gravida with an intermediate risk on double marker with ventriculomegaly. So ventriculomegaly was a mild ventriculomegaly with 10 and 11 mm at 16 weeks. Now, if you done a karyotype, you're not going to pick up this, but here what came out is a 2p21 microdeletion, which had the 6-3 gene within it. Now, this gene causes holoprosencephaly. So obviously, this was a likely pathogenic variant. It was not there in the parents, and this was classified as a pathogenic variant later. So essentially for these cases, it's always advantageous to consider a microarray over a karyotype. Okay. Now this is another case of 22q microdeletion, 2 recurrent cases of a conotruncal heart defect. Obviously, if it's a one pregnancy with a conotruncal heart defect, the risk of recurrence is usually discussed to be low as 1%, but this lady landed up with a second child with a similar issue, and one of the parent carried a silent 22q microdeletion. So 22q microdeletion or DiGeorge syndrome can have a phenotype of almost normal individuals who even reproduce and do not have major features, but once we find in the babies, we do find them to be abnormal. Then molecular testing. So molecular testing is essentially, we are offering, it should be offered with proper counseling. Prenatal diagnosis cannot be offered. Now a previous child has intellectual impairment. You cannot directly send the patient, do an amniocentesis. You need to identify the exact point. That is, I give an example, I keep 25,000 pages in front of you and ask you to search for something which you don't know. You won't be able to search for that. So you need to identify the mutation. Only then we are in a position to offer a prenatal. So when to send the patient to a genetic or a fetal medicine evaluation, it should be ideally preconceptionally. So if they have had a child who has had intellectual impairment, they should be coming preconceptionally ideally. But even if they come to you with a pregnancy at the first visit, it should be around 6 to 8 weeks that they should come over, because we would have sufficient time to investigate at least the index case as a singleton or a trio and still be able to offer a good prenatal diagnosis. So if we have some mutations which have been identified, like for example in this particular child who passed away with Zellweger syndrome or peroxisomal disorder, and there was a known PEX10 gene mutation which was there, we can, parents testing was done, and we can easily offer a prenatal testing based on this finding. But sometimes patients come to you with a pregnancy and there's some history which is available. Now, in this case, the lady came to us with at 12, 13 weeks with a high NT. NT was 3.3 mm, and the dual marker showed surprisingly some low risk. So she came and she had a positive family history. Now, usually as geneticists, we would dig deeper into the history and we asked for the photograph of the child. Now you can obviously, anyone can say that this child is extremely dysmorphic. So obviously she had seizures, spasticity, etc. So in this case, we just can't do a karyotype or a microarray and leave it at that. So in this case, we did a trio-exome evaluation, and the lady was found to be a heterozygous carrier for this ATRX mutation, and the fetus was affected. So if you would have just offered a karyotype and sent her home, she would have landed up with a child who would have been similar to the brother. So a raised NT is not Down syndrome alone, is what we must remember. If you're planning a molecular test which is more expansive, like for example, you want to do an exome, ideally to do a trio-exome in these cases, that is fetus along with the parents, or you investigate the index child thoroughly and then offer a prenatal testing, that is most ideal. The very important pitfall is the variants of uncertain significance that we come across. Now, almost 60–70% of the times, variants of uncertain significance may not have an actual correlation with the phenotype sometimes. So what is very important is whether the index child has been appropriately diagnosed or not. Now this is a case when it was suspected to be a Leigh syndrome, and one gene was identified pertaining to Leigh syndrome in the previous child. Now if we offer a prenatal based on this, we could have been wrong because it was present in one of the parents. The mutation was actually located in some other gene, which was later found on data reanalysis. So a genetic evaluation helps in whether we are offering a correct prenatal testing for the correct point or not. then I would get at least about 3 to 4 patients a month who would come for teratology counseling. I've taken some medication or I've had some infection or, all these, some radiation exposure, and we want to understand. Now, this is a case just from this week. A 10-week primigravida, non-consanguineous, no positive family history, came with a chickenpox at 8 weeks of pregnancy. The question was whether to continue the pregnancy or not. We must know the timelines for this. So essentially, she had this virus exposure at around 8 weeks. And between 8 to 20 weeks, the congenital varicella syndrome is most severe. So it affects almost 2 to 15% of the babies. And they could have skin abnormalities, ophthalmic issues, they can have CNS, major CNS abnormalities, etc. So we have to counsel them appropriately that what we expect is 2 to 15% babies would be affected. Whether you would want to risk continuing the pregnancy, then we only have to follow up on scans. Nothing else possibly can be done in this case. So we could give the guidance as to what investigations, like for example, you need to look at hydrocephalus, evolving microcephaly, all these things need to be looked into. But if the exposure is beyond 20, near term, there's no major risks which are involved for the fetus. And generally around the perinatal period, it could be neonatal lupus, which is neonatal varicella, which is not very severe. So in these cases, proper counseling would help couples take an informed decision as to whether they would want to continue the pregnancy with risks or discontinue. Now, this couple has come to me at 6 weeks. So these are some social implications of prenatal testing that I would want to discuss. Prolonged infertility of 6 years with poor semen quality, multiple IUI, IVF attempts have failed. There was a translocation in the husband and which was causing all these issues, and they had a natural pregnancy. Now, the NT scan was normal, but double marker showed an increased risk, and for which an invasive testing was done, and that showed a 16p microdeletion. Now, it was nothing related to the chromosomes of, which were there in the parents. It was chromosome 1 and 2 in the father, but this showed a 16p microdeletion. Now, then it's labeled as likely pathogenic. Obviously, the first thing that comes to us, it's likely pathogenic, discontinue the pregnancy. But the couple really was very keen on continuation. So in this case, how do we approach? What is one thing is we have to do a parental array. So if parents, it's maybe present in one of the parents. And on literature search, it is found that this region has a lot of deletions and duplications, which in majority patients may not have any major implications. So the thing is that you have to counsel them that if it's present in one of the parents, and so usually of the same size deletion or duplication, then possibly we are dealing with more normal outcomes than not. So then you leave the choice to the parents whether they want to continue the pregnancy with those small risks or want to discontinue. So counseling, pre and post-test counseling, genetic counseling is essential for all these. Now in this case again, 2 babies, there were 2 neonatal deaths, like usually they come across, and Dr. Neeraj would know. 5th day, hypoglycemia, sudden deterioration and death. There was no diagnosis, but we ultimately found that this particular gene, MC2R gene mutation, was there in the parents. I offered a prenatal diagnosis about 4-5 years back, and the daughter is now normal. They came with the next pregnancy, and this pregnancy is affected. Okay, so there was a homozygous mutation which was there in the first 2 kids. It is again there in the first pregnancy. So what you need to do in counseling, you have to explain both outcomes, good as well as bad. Now in this case, obviously they have had 2 babies who have died, so they know what the outcomes can be. But the father came for counseling from somewhere from Akluz only, they came there and essentially was asking, can I continue this pregnancy? I am willing to take risks. So in this case, then you have to tell them that this is one of the treatable conditions. See, as a geneticist, I manage cases postnatally as well. So we know that familial glucocorticoid deficiency, if you treat them properly early in the neonatal period, they can have good outcomes. So almost more than 90% good outcomes if good perinatal care. So the importance of perinatal care, so we told them that it should be an in utero transfer. Then once the delivery should not be taken stretched to term, there should be a little early cesarean section around 36-37 weeks. You deliver the child, will be shifted to the NICU, will be monitored by the endocrine genetics and the neonatal team. And then obviously we are going to have possibly good outcomes in more than 90% cases if you manage it well. So this is the overall counseling that should ideally happen, not rather directly discontinuation of pregnancy. Obviously, you give them both the options, but let them choose. Another case wherein a good antenatal and perinatal management helped in improving outcomes. This older child is my case of VLCAT deficiency, who's under my treatment. The second child died in the it's just one slide. The second child died in the neonatal period, possibly because of the VLCAT deficiency, and she came with a third pregnancy. Now, again, the fetus was affected with the same condition, VLCAT deficiency. Now, what we know is there are two treatments. One is carnitine, and second is what is called as MCT oil. So MCT can be given to these patients. So what we did, the mother was started with carnitine and a high MCT diet in the pregnancy itself. So if we do not, then sometimes it can lead to neonatal or very early, sometimes they can cause stillbirths also. So to prevent that, we started the mother on carnitine and MCT throughout the pregnancy, and postnatally the baby was born, showed classical biochemical signatures of the VLCAT deficiency, but is absolutely normal at 2 years, no symptoms whatsoever. So essentially, to give good outcomes, you have to counsel the patients properly. Now it's like a happy family of 4 now. So this is how, proper counseling helps in improving outcomes. So my take-home messages would be, if it's a low-risk case, obviously you're going to give your routine vitamins. Thalassemia screening should be a routine. Down syndrome screening should be routine. Standardized NT and biochemistry should be done. NIPS can be given as an option. Abnormal scans or markers should prompt a proper evaluation of these families. Cases with bad obstetric history or previous children affected, we should try to reach a correct and definitive diagnosis, because that's going to be a big problem going further, because wrong diagnosis can lead to major issues later. So timely referral to the genetic clinic and counseling is very, very crucial, and ideally no family should be left in the era of genomics. So it's like a teamwork, wherein the geneticist, us along with the fetal medicine experts, with the obstetricians, and as well as sometimes other subspecialties also need to be involved to give a really good outcome to babies. Thank you so much.
Genetics is where we come from. It's deeply natural to want to know. Thank you, Dr. Chaitanya Datar, sir, for that enlightening talk packed with valuable insight. The topic is open for discussion. Any questions?
Yes. See, consanguinity is common, especially in this area. Almost 30 to 40% marriages are in consanguinity. So when there's consanguinity, we'll go deeper and look at the history properly. That is number one. Number two, if there is no significant bad obstetric history as such, it's not mandated that all patients should undergo a genetic evaluation. But nowadays, karyotype is not going to help, because it's just going to look at the chromosome from outside. It is not looking at genes. It's falsely reassuring. So nowadays, the option of something called expanded carrier screening, which is exome-based, that can be possibly offered. Like, for example, you're doing an exome evaluation in the couple, okay, based on certain common genes at least, and you're screening them. So some of the other genes which are not covered on exome is something called SMA, spinal muscular atrophy, which is a very common disorder, which usually you should screen separately. So that's something called expanded carrier screening in couples. That option can be discussed with the couples if they want to consider this. Nowadays, some people do come to us, even premaritally also sometimes, for counseling, that we are wanting to marry this. Do we have some tests to prevent that? So as an option, you can offer, but it's not mandated for sure, unless there is a bad history as such in the family. Yes, ma'am. Yeah, so usually in oligoasthenoteratozoospermia, one thing would be a basic karyotype, number one. Second, you go for a Y chromosome microdeletion, because usually the AZF, B and C sometimes can just have an oligo. Just for counseling purposes, you can do that. What we find nowadays, especially in azoospermic patients, we do find single gene problems, that is primary spermatogenic failure related genes coming up. Now what happens in these patients, you try to do a TISA or this thing PISA, you will not get any sperm, or sometimes, so there's no point in going for their own gametes in those cases if they are found to have a primary spermatogenic failure related genetic single gene abnormality. Karyotyping always as a first line test, along with you can offer a Y microdeletion, obviously, along with DFI corrections and all those things that you would do. Yeah, it's not always. HELP syndrome higher risk in when the baby is VLCAD. That's absolutely correct. If the baby is affected with VLCAD, there's almost a 20 to 30% risk of HELP syndrome in mothers, but 70% won't have that. That's true. Now, in this case, the parents definitely wanted to continue the pregnancy, so we started antenatal treatment, because if the baby doesn't get enough, the MCT, the medium chain triglycerides, the baby will, sometimes they can be an IUD, or sometimes a stillborn baby, or immediate neonatal death that happened earlier. So for that, we give carnitine and MCT both pass transplacentally.
I request Dr. Mohite sir to felicitate Dr. Chaitanya Datar sir. I request Dr. Gundevar sir to felicitate chairpersons.
Thank you very much, sir, for a lucid and very elaborative lecture on the antenatal screening. Thank you, sir, for very lucid and elaborative lecture. Your example of a library was very well said. So, as the saying goes, don't judge the book by cover. So, thank you very much, sir, and thank you very much.
I request Dr. Gundevar sir to felicitate chairpersons. Next lecture is on polyhydramnios by Dr. Sumit Chamare sir. I request Dr. Rajiv Dabde sir, please come on the stage to chair the session. He is one of the most renowned gynecologists and obstetrician from Solapur. He is consultant at Navajivan Fertility and IVF Center, Krishnamai Nursing Home, Solapur. He did his MD from Shivaji University. Also has done advanced laparoscopy and hysteroscopy training. I request Dr. Shashikant Umbardhan sir, please come on the stage to chair the session. He is MD, DNB, DGO, FCPS, Director and Consultant at Mangalya Nursing Home and Atharva Fertility Center, Solapur. Associated Professor at Ashwini Rural Medical College, Kumbhari. Executive Member at MSR 2016-18. Organizing Secretary at Sion 2018. Founder Director of SIMS Fertility Center, Solapur. I request Dr. Sharad Shirke sir kindly come on the stage to chair the session. He is a senior obstetrician and gynecologist consulting at Shirke Hospital, Mangalveda. I request Dr. Vivek Gundevar sir, please come on the stage to chair the session. He is a senior pediatrician practicing since 25 years. A brief introduction about Sumit Chamare sir. Sumit Chamare sir has done 3-year fellowship in fetal medicine, completed MS OBGY from prestigious GS Medical College, KM, Mumbai, received Best Paper Presentation Award at CUSP 2016 and 18, certified member of FFM London for anti-scan.
Good afternoon, everyone. To begin with, why this presentation was chosen. Why did we opt to take the topic of polyhydramnios? So we all do growth scans between 28 to 38 weeks. We all do encounter polyhydramnios, but what do? We limit our investigations to maternal blood sugar levels to rule out GDM, or next point, if the lady is not having gestational diabetes, we ask the pediatricians to have a look for the postnatal tracheoesophageal fistula or intestinal obstruction. But now I am going to take all of us through three cases, a case series of three, wherein we will see that polyhydramnios is much more beyond GDM and the intestinal obstructions or TO fistula. So the first case, Mrs. ABC, 23-year-old, married for 2 years, non-consanguineous couple, primigravida, blood group B positive, 51 kg was her weight, no significant medical, surgical or family history in the past, was referred to us in view of polyhydramnios at 33 weeks of gestation. Her previous scan, at NT scan, which was done at 12 weeks, the CRL was 55, NT was 1.7 mm, nasal bone was present, aneuploidy screening test was not done. At anomaly scan, 20 weeks, normal Likert, normal Dopplers, biometry was corresponding to 20 weeks, so all good till now. At growth scan, at 32 weeks, there was increased Likert, the stomach bubble was well seen, and there was no cleft lip noted. So these were the previous scans with which she had come to us. And at our scan, we found that the single deepest pocket was of 13.6 centimeter, which is actually a significant polyhydramnios. So ruling out the maternal causes for polyhydramnios first, we looked at her blood sugar levels. Her GTT was done at 26 weeks. The fasting and post 2 hours, 124 was absolutely normal. We looked at her blood group to rule out, to look whether we were dealing with a case of isoimmunization. So the blood group was B positive. So even that part was ruled out. Maternal medication or drug intake history, there was no history as such of steroid or any other medicinal usage. So we had ruled out the maternal causes for polyhydramnios. Moving on towards the fetal causes for polyhydramnios, structural anomalies, we looked out for the cleft lip, nothing was there. The stomach bubble was well filled, there was no intestinal prominence or any dilated bowel loops were noted, the bladder looked very good. Again, going into a little more depth of the fetal causes for polyhydramnios, we looked into the rare cases, like we have the neuromuscular anomalies, the neuromuscular disorder like arthrogryposis or FADS, that is the fetal akinesia, can cause polyhydramnios. But even that, there was no evidence of club feet or contractures. So good fetal movements were noted on scan. So the hunt for the cause continues. So we again thought of even more rarer things, like we can have the cleft of the palate, so for which we looked out to see the profile view to look if there is any cleft in the palate, and that's where it struck us that the fetus has a very small chin. On 3D rendering, we can see that the nose is very well seen, the lips are very well seen, but here we can see that the chin of the fetus is actually very small. So it was a case of micrognathia, and finally we had found the culprit. It was a case of severe micrognathia which was causing the polyhydramnios in this patient. So the first case, we have a rare structural anomaly which is causing the gross amount of polyhydramnios. Moving on to our, so why the polyhydramnios is seen in the cases of micrognathia per se? We have a small jawbone which causes no mouth opening. There is impaired fluid deglutition, and that leads to polyhydramnios in these cases. Neonatal demise on day 3, and the pediatrician said that the baby has a Pierre-Robin syndrome. Moving on to our case 2. 23-year-old, married for 1 year, second-degree consanguineous couple, primigravida, Rh positive blood group, no significant medical, surgical or family history in past, was referred to us in view of increased risk for trisomy 21 on quadruple marker test at 17 weeks of pregnancy. On the ultrasound which do before any invasive procedure, we found that there was even an echogenic bowel loop. So there was a test which was a quadruple marker test which was positive which showed high risk for Down syndrome. We had a marker for Down syndrome. So the decision for invasive test was taken and we did an amniocentesis at 17 weeks. But despite of these two findings, we found that the FISH21 and even the karyotype was normal. So far, so good. Further course in pregnancy, anomaly scan was done at 21 weeks. At her native place, there were no obvious anomalies. And this patient returned back to us at 34, where the linear structure, non-vascular ones with the measurement of more than 15 mm. We defined a dilated bowel loop when the diameter of the bowel is more than 15 mm. Or here, this is another case where we can see that there are echogenicities within the bowel. But here we can see something like the honeycombing. So this was not a typical case of dilated bowel loop, but as it was a 34 weeks, there was polyhydramnios, the pregnancy was just continued, and she delivered at around 37 weeks. There was a male child which was born limp with poor Apgar score, shifted to NICU, had severe diarrhea, electrolyte imbalance, and succumbed on day 2. The clinical exome sequencing test was done, and this was the report. We found that there was a disorder called congenital chloride diarrhea, which the baby was affected with. So what is congenital chloride diarrhea? It's an autosomal recessive condition, causes persistent secretory chloride losing diarrhea. Postnatally, there is dehydration, hypoelectrolytemia, there is abdominal distension and failure to thrive. Why all this testing is important? Because as it's an autosomal recessive condition, there is up to 25% risk of recurrence in the subsequent pregnancy. So the first case, we saw that there was a structural anomaly in the fetus, and second case, we dealt with genetic issues. Moving on to our third case. A 27-year-old married for 3 years, again a third-degree consanguineous couple, gravida to abortion 1 with Rh positive blood group, was referred in view of polyhydramnios at 32 weeks. Antenatal course till now, the anti-scan was fine. Anomaly scan, the Likert was little on upper side with single pocket of 7.2, but however, there were no structural anomalies noted. At 27 weeks, the Likert was increased. There was a single pocket of 10. The anatomy was grossly normal. Patient was started on indomethacin outside, that is 75 milligram, and she took it for 5 weeks before she came to us. At 32 weeks, when we did a scan, the single pocket was 14 centimeters, so that's a significant polyhydramnios. The stomach bubble was good. There were no loops of intestine which were dilated. We stopped her indomethacin due to the risk of the fetal complication and asked her to follow up again after 2 weeks. At 34 weeks, the single deepest pocket had increased to 19 centimeter with AFI of 13. Literally, the whole abdomen was full of Likert and no fetus was easily seen. We did amnio reduction at 34 weeks. We gave her intramuscular progesterone. Risk of PPRM was explained. Around 3 liters of amniotic fluid was removed. Here is the image of the procedure which was done. And we stopped the procedure when we removed around 3 liters of procedure, and the single pocket had come down to 10.5 centimeter at the end of the procedure. Again, she needed an amnio reduction at 36 weeks of gestation because the fluid had recollected in 2 weeks time period. Patient delivered at 38 weeks by LSCS for breech presentation. Neonate had frequent urination at birth and electrolyte imbalance. This is when the geneticist had come in picture and the further tests were carried out. So the blood which was sent for genetic mutation testing showed a pathogenic variant for the Bartter syndrome in the baby. Parents were found to be carrier for the mutation on subsequent testing. And again, the inheritance for this disease is autosomal recessive with 25% chance of recurrence. So what is the take-home message for all these 3 cases which we have just seen? Let's see it in the English way. Our eyes don't see what our mind doesn't know. So from today's conference, we have seen NT scan, we have seen anomaly scan, how it's to be done. We had a talk by Datar sir on genetic. So let our mind know what we have to see so that our eyes can see from next time we are doing a scan. And this is what the first case teaches us, to know more, and so that we can do more for our patients. The second case teaches us that all that glitters is not gold. Similarly, all that's dilated is not obstructed. In fact, the second case which we saw was not of a obstructed bowel. The case had diarrhea when the baby was born. So this is the typical honeycomb appearance which is seen on antenatal scans when you are dealing with a case of congenital chloride diarrhea. And third case tells we gynecologists or obstetricians that delivery is not the end of the story. Picture abhi baki hai mere dost. Have the pediatrician and the geneticist in the loop so that we can help the patient in this pregnancy as well as in the subsequent pregnancy. So what is the take-home message from these three cases? That polyhydramnios, yes, a common finding. Do not be aware of the rare thing. Do not be afraid of the rare. Just be aware of the rare. Thank you very much.
Thank you, Dr. Sumit Chamriya, sir, for raising awareness on polyhydramnios. The topic is open for discussion. Any questions? Next lecture is by Dr. Ajit Gandhi sir on diagnosis and management of Rh negative pregnancy. Our speakers needs no introduction. They have left an indelible mark in the field of fetal medicine. Please give a warm welcome to Dr. Ajit Gandhi sir. Dr. Ajit Gandhi, sir, he is MBBS MS OBGY from VM Medical College, Solapur. He got diploma in endoscopic surgery in Kiel, Germany in 1997. Certified anti-examiner FMF London 2009. Presented and published various papers in national conference and journals. He served at various posts in OBGY Society, Solapur and IMA Solapur. He is PCPNDT committee member actively involved in preventing fetal feticides.
Good afternoon, everybody. I have selected some rather odd topic from the whole day's stock, and we'll be looking at the fetal anemia, which is usually not, somehow is neglected in conferences and CMEs. There is a reason. Before we go to the fetal anemia, there are the terminology about are the various names by which it is recognized is hemolytic disease of the newborn, erythroblastosis fetalis, red cell alloimmunization, and red cell isoimmunization. Most commonly we call it as a isoimmunization. Now, when we see to the history of management of fetal anemia, it's something is a epic success in the story of medicine. Like we have conquered the smallpox, we have conquered the polio. Here is something, it is similar to that there has been a lot of change in the management of fetal anemia in just last 60, 70 years. if we look back, 1940 was the beginning of all this when the Rh rhesus antigen was identified by the Landsteiner. It was followed by the Levin and Associates who established the causal relationship between Rh antibodies and the Rh negative gravida causing hemolytic disease of the fetus and the newborn. The Wallerstein in 1945, he did the first neonatal exchange transfusion. Bevis and Lilly in 1956, they found that the amniotic fluid bilirubin was increased, and they developed the famous Lilly chart. And the Sir William Lilly, he did the first intrauterine transfusion based on this Lilly chart. If we remember, those who are seniors in this, we have gone through those all Lilly charts, the optical density at 450 by spectrometry, and then plot the graph and see whether there is fetal anemia. So all these things that was done, and in 1963, Lilly first did the first intrauterine transfusion. That was fluoroscopic. That was using the X-ray. What he did was he injected a radiopaque dye. The dye was swallowed by the fetus. Then the needle was put after looking at the opacified bowel, and then he put intraperitoneal blood. That was the first success. And it is the Lilly who coined the term fetal medicine. And that is how the fetal medicine was born. Subsequently, the next breakthrough came with ultrasound. Ultrasound changed the whole thing dramatically. It was in 1980 that the first intraperitoneal transfusion was done with the help of USG. In 1981, it is the Roddick who used FETOScope to do the intrauterine transfusion. In 82, Bang and co-workers, they did the intravascular transfusion using the ultrasound. 1990, one more breakthrough came, and that is the genetic technique for defining the red cell typing, whether the fetus is Rh positive or negative. Okay, that was in the 1990. One more breakthrough was in 1997 when gentleman Lowe, he could diagnose the fetal Rh from the circulating fetal DNA in the maternal blood. So that was another breakthrough, and I'll come to that when we are going for the management of this condition. 2001, the thing came when the Lilly chart became historical, and Doppler came into picture for monitoring and diagnosing the fetal anemia in a non-invasive way. If you look at the Lilly, those things, you had to do the amniocentesis and the spectroscopy, and it was quite a complicated and imprecise method of diagnosing the fetal anemia. And by the time the bilirubin would start rising into the amniotic fluid, it was quite late that the diagnosis would be made. The Doppler made us diagnosing the fetal anemia at quite an early stage, and it's a very easy thing to do the middle cerebral artery Doppler. We'll come to that, and the learning curve of this particular technique is very low. One can easily start doing the middle artery Doppler and see for the fetal anemia. Sorry. So what are the today's learning objectives? One is to create the awareness. Now, though everybody knows that patient is a Rh negative, what we see in the day-to-day practice is now the things have changed over the years. When I started my practice, even the blood group, doing the blood group was a rarity. Now blood group is compulsorily made. But then, when the patient is found negative, the next step is forgotten or is not being done consistently. That is the father's blood group, and if the patient is multiparous, the blood group of the previous babies. Knowing this, if the father is positive, or if the previous babies are positive in case of heterozygous father, then you would be looking at this case more carefully for any evidence of sensitization. That is step one. And second is the indirect Coombs test. Indirect Coombs test has to be done in each and every Rh negative gravida having a positive husband or previous children who are positive. Now that when to do the indirect Coombs test, the first test is to be done at the first visit, preferably whenever she comes in the first trimester, second trimester, whenever she registers with you. And the second test is at 28 weeks, and subsequently, if you find it positive at any of those gestational ages, then you have to monitor it every month. Every month you have to do the IDCT or indirect Coombs test. Now there is something about the Coombs test. The conventional Coombs tests are done in the saline and the albumin methods and all those things. Those are all insensitive methods where you are likely to miss the sensitization in almost 30 to 40% of the patients. The newer technique of gel column indirect Coombs test is sensitive, very specific, and is very less likely to miss the sensitization. So whenever you ask for a IDCT, you ask for the gel column method. There are many still old laboratories or many laboratories who are following the old technique of saline and the albumin suspension and those kind of things. So just ask not to do with that method, specifically ask for gel column method. So that is about the non-sensitized gravida in a conventional thing. Now, sir, there are certain new things which have come which will help you to manage these patients in a better way. And the thing which has come is a non-invasive diagnosis of fetal Rh. You can do the fetal Rh diagnosis in a NIPT test. Now that is available. That is done at my center. What we do is at 12 weeks NT scan, we send the NIPT along with the diagnosis of the fetal Rh. The cost would be around 20,000 rupees, but then you will be getting the information about the aneuploidy plus knowing whether the fetus is Rh positive or negative. If the fetus, if you find that the fetus is negative, the whole process of monitoring her in the further pregnancy is not required. If you find that the fetus is positive, obviously you put the protocol for monitoring her for any possibility of sensitization. That is one thing which has come in the armamentarium of investigations. The second thing which has come is knowing the zygosity of the father. The zygosity of, if the father can be homozygous for the Rh antigen, if he is homozygous, all his babies are going to be Rh positive. But if he is heterozygous, there is a chance that 50% of the babies will be Rh negatives. So if he is heterozygous, then you would be subsequently looking at the fetal Rh. If it is negative, again your trouble of monitoring the baby fetus for the sensitization is reduced. So these are the two new things which you can use in your practice to monitor these babies in a better way. Now, second objective is management of diagnosis of sensitization. We will come to that. Once we diagnose, it comes to the management, and we look at certain new things which have come in the research, and maybe that would make another breakthrough in the management of the Rh. Perhaps the intrauterine transfusion and those things would go away when this research comes into the reality. I'll come to that point last. Now, as I was talking about knowing and anticipating and awareness about this, the history, the blood group workup, the laboratory evidence, and most important is, of course, ultrasound and the middle cerebral artery Doppler. Now, to know something about the intricacies of the Rh antigen. In total, there are 3 antigens, the C, D, and E. The C capital C small, D capital D small, and E capital E small, they stand for the dominant and the recessive gene. And besides that, there are some other blood groups like Kale, Duffy, Kid. And those things can also cause Rh isoimmunization or fetal anemia. This is still not much seen in our practice. In my practice only, I have seen one case of C anemia which required treatment. Otherwise, all those were the classical D isoimmunization. Now, something about the Rhd antigen. The Rhd antigen, this is a pictorial presentation which codes this D protein codes the Rh, the RBC. Now here is something, there is a, sometimes you get that the blood group is D weakly positive. Then what to do? The reason for D being weakly positive are two. Number one is there is a decreased expression of Rhd gene on the surface of the RBC so that you get a weak D. Now this weak D is to be treated like a positive D, Rhd positive patient. So she will be like any other Rhd positive patient. Now second is something is a tricky situation where there is a mutation in the Rhd gene, and then there is a mosaic Rhd antigen on the RBC cell, and that's why the test weak on the laboratory test. Now this is also to be treated as a positive patient. Now there is one thing which is called as a Rhd pseudogene. Now what happens is the genome of the RBC is like any other Rhd positive cell, but then there is a stop codon in the intron between exon 3 and exon 4. As a result of this, the D protein which should code the RBC and should make them Rh positive doesn't happen. So when you do a serological testing of such patient, you will get a negative blood group, when in fact they have a Rhd positive gene. Now the dilemma comes when we do a NIPT in such patients. The NIPT will come positive in these patients, whereas the conventional laboratory testing serotyping of the RBCs will give you the negative. This is a very rare theoretical situation, but then one should remember that there is something like a Rh pseudogene. There are many causes of non-immune anemia also. It's not that always only the Rh isoimmunization causes the anemia. There are many other causes. Like the congenital infections, the TOJ, the parvovirus can cause a fetal anemia. There are some inherited anemias, the alpha thalassemias mainly, then the bone marrow disorders, fetal placental tumors like the choriangiomas, the vascular malformations in the fetus like the then the placental pathology, massive fetomaternal hemorrhage. There are some rare genetic disorders, and as a complication of monochorionic placentation. In the morning session, we had the plethoric baby and the anemic baby, and then the ablation and the intrauterine transfusion. So this can happen as into the monochorionic twinning. Then which pregnancies are at risk? It is the previous history of hemolytic disease of the fetus and the newborn. If there is a previous history, these are the pregnancies which are definitely at risk. Then causative antibodies are identified on routine maternal blood group screening. When you do the IDCT, you will find that the IDCT is positive. Now something we look at the IDCT in a dilution, 1 in 4, 1 in 8, 1 in 16, 1 in 32. Now what is this and when to give the significance to this test is when you find that the titer is 1 in 32 or more than 1 in 32, then it is a significant titer and that is likely to cause a fetal anemia. Titers which are less than 1 in 32 are usually will not cause a fetal harm, or at the most will have a mild fetal anemias, but then subsequently you have to monitor these titers. If you are finding that there is a rising titer, that is something is pointing towards a problem. This I told you already, the paternal genetic typing. Then non-invasive, yes, I spoke about this. Now, another important thing is about giving the anti-D. This is again, one has to understand thoroughly. See, there is something which is called as a feto-maternal hemorrhage. How the sensitization occurs is by the hemorrhage, the fetal RBCs enter into the maternal circulation. The B lymphocytes recognizes them as a foreign structure, and then they would start producing the antibodies. The initial response is a IgM, later is a IgG. The initial IgM response comes within 4 to 6 weeks. The IgG response comes from 6 weeks to 9 months. So that is the how the antibodies are produced. Now, what about the feto-maternal hemorrhage? Feto-maternal hemorrhage can occur right from the first trimester till the delivery. Now, usually in the first trimester, there is a 3% chance of feto-maternal hemorrhage in a natural normal pregnancy, if there is no any other problem. And that feto-maternal hemorrhage could be max to max 0.1 ml. But the same feto-maternal hemorrhage would go to about 45 ml in the third trimester, and the chance of the fetal-maternal hemorrhage can go up to the 25 ml at the time of delivery, and the chance of feto-maternal hemorrhage is almost 45%. So at the time of delivery, the chance of feto-maternal hemorrhage is very high. The procedures like the amniocentesis, chorion-villus sampling, induced abortion, abruptio placentae, manual removal of the placenta, IUD, these are the things which increases the risk of feto-maternal hemorrhage more than what would happen in the normal pregnancy. Now, once there is a feto-maternal hemorrhage, what is the risk of sensitization? If there is 1 ml of feto-maternal hemorrhage, the risk of sensitization is about 15%. But if this feto-maternal hemorrhage goes to 25 ml, the risk increases to 45%. If the same fetal-maternal hemorrhage goes to 250 ml, the risk is almost 60 to 70%. So more is the feto-maternal hemorrhage, the more is the risk of sensitization. So then how you prevent the sensitization is by giving the RHD immunoglobulin. The normal dose which we give is 300 micrograms. Now this normal dose, 300 microgram, would neutralize about 30 ml of feto-maternal hemorrhage or 15 ml of fetal RBCs. So in a normal pregnancy, normal delivery, you expect that a 300 microgram of dose would suffice. But in the situations, just I listed you the IUD, the placenta, this thing, abruption and those things, that the risk of fetal-maternal hemorrhage volume is high, and there you can either do a KB stain, Betke stain. There you identify the fetal RBCs by alkali elution, and then you calculate the dose of anti-D. That is the ideal way. But if you don't have this facility, you can double the dose of anti-D empirically in such situations and reduce the risk of sensitization. Before the advent of anti-D, almost 10% of the patients used to get sensitized during their first pregnancy. With the advent of NTD at delivery, one dose at delivery, the risk has come down to 1 to 2%. One more additional dose at 28 weeks, 300 micrograms, has reduced this risk to 0.1%. So that is something which is very significant. From 10% to 0.1% is a great success, where we have reduced good number of sensitized patients by just using the NTD. So always remember to give the NTD whenever you find that the fetus, a baby which is born, if it is Rh positive. In the negative patient, of course, you don't have to give the negative baby, you don't have to give the injection NTD. Now there is something monoclonal and polyclonal antibodies. Now those polyclonal antibodies are almost not there in the market. But essentially the polyclonal antibodies are more efficient than the monoclonal antibodies. Right now we don't have the choice in the market. All those are monoclonal antibodies. And we do see the cases of sensitization after receiving the monoclonal antibodies in the previous pregnancies. That is the thing. But still, there is no consensus and there is no clear guidelines. They should come from the government actually. Now about the intramuscular route and there are NTD preparations which are now intravenous available. There is no any distinct advantage. You can give it intramuscular, you can give it intravenous. Deltoid is the preferred site than the than the buttocks. It gets better absorbed from the deltoid than the buttocks. Now, diagnosis of sensitization. See, what is the definition of fetal anemia? Whenever there is a less than, there are different ways of defining it. There are researchers who have defined it on the hemoglobin deficit. There are researchers who have diagnosed it on the hematocrit. Now, the most commonly followed is the hemoglobin, which is a pioneering research done by the fetal medicine group, the Nicolai and those people. So how you see is when there is a deficit of 2 grams of hemoglobin in the fetus, that is called as a mild. When the deficit is 2 to 7 grams, it is moderate. And when the deficit is more than 7 grams for the expected gestational age, hemoglobin for the expected gestational age, there is a nomogram of normal hemoglobin for the gestational age. So when you take those hemoglobin figures from the nomogram, and then you see the deficit, if it is more than 7 grams, it is a severe anemia. The easiest way is hematocrit less than 30%. It applies to all the gestational age because less than 30% hematocrit is almost 2.5 mom for all the gestational ages. So that is the easiest at hand thing. If you look at the CBC value, if the hematocrit is less than %, the fetus is grossly anemic. It is the, as I was telling about the Doppler velocimetry of the middle cerebral artery. What you do is you do the Doppler velocimetry. Now there are some things which when you do the technique you have to follow is number 1, locate the middle cerebral artery by putting the color. Number 2, once you put the color, select the proper gate size. If you keep it too big outside the vessel, you may not get a correct velocity. If you keep it too small, then you would get a velocity which is slightly higher than the expected one. So you put the gate size exactly like the vessel size. Now third is the angle. Your angle has to be less than 30 degrees. Middle cerebral artery usually does not create angle because usually it comes in the 0 degrees, but if the head is oblique, especially so in the second and third trimester, maybe you may exceed the angle of 30 degrees and then you will get a erroneous or wrong velocities. So always you have to look at the angle, and the angle has to be less than 30 degrees. Ideally it should be 0. Once you do that, your gate has to be placed on the part of the vessel immediately when it originates from the circle of Willis. If you put your gate more distally on the middle cerebral artery, you will get erroneously low velocities. The gate has to be immediately after the origin of the middle cerebral artery, and then you measure the velocity. After you measure the velocity, how you interpret it? Like 10 minutes. How you interpret is, you have this fetal anemia chart where you put your values on the chart and you look how much fetus is anemic. The 1 mom is a normal value, 1.2 is a mild anemia value. Anything which is more than 1.5 mom requires a fetal blood sampling. Now, here is a typical hydropic fetus. You can see there is a ascites, there is a scalpedema, there is a pericardial effusion, cardiomegaly, hepatomegaly. So this is a classically hydropic fetus due to anemia. When the hydrops develops, usually in the RH isoimmunization, it is the ascites which comes first. Then comes the mild pericardial effusion, then comes the pleural effusion and the generalized anasarca. So these are usually this is how usually the hydrops progresses in isoimmunization. Once you find that this mom value is 1.5 or more than 1.5, you have to go for a blood grouping, for the fetal blood sampling. Now fetal blood sampling, I will come to that. And what you look into the blood sample is typing the direct Coombs test, the nucleated cell count or the retic count. And of course, you store the DNA for any future investigations. It is not that we look to the case only with the view of that this fetus is anemic. Maybe that the fetus could have some background genetic disorder. Goes wrong with this is about you can do at the umbilical cord insertion site, and the second site is the intrahepatic umbilical vein. Now, I did the first intrauterine transfusion in 1992 with the then Aloka machine 630 and that was an intraperitoneal one. I was doing those intrauterine transfusions till to 2015 intraperitoneally. After 2015, I switched on to intravascular, and last 4 years I haven't done any intraperitoneal transfusion even for a 20-weeker baby. It's all intravascular. So almost I must have done more than 250 intrauterine transfusions in more than 100 babies, 100 patients. My fetal loss is about 10%. Those fetal losses were mainly in the first, in the early sensitizations between 21, 22 weeks, and those with a very severe anemia and come with a gross head drops and just pre-moribund or pre-terminal fetuses where could not salvage those kind of babies. Now, for giving the intrauterine transfusion, you have to paralyze the baby. If you paralyze the baby, your complications are reduced by 80%. If you don't paralyze, the baby would move and would create some complication, like if you are doing a cord insertion, laceration of the cord, or piercing through the cord, or it could be something, liver injuries if you are using an intrahepatic umbilical vein. So paralysis is must. And how it is done is by, I use Vecuron, 0.1 milligram per kg. We do the estimated fetal weight, and that is used as calculating the dose of Vecuron, that is 0.1 milligram. I give it on the fetal thigh or fetal buttocks before starting the procedure. The fetus gets paralyzed within 5 minutes, and after that, start the procedure. This is how the things which are required. You can see the different blood collection tubes required, mainly the EDTA and the plane which is required for carrying out the DCT, the different syringes, the bivalves, the connectors, the long needle in case the fetus, the patient is obese or if the pregnancy is more than 32 weeks, you may not be able to, your spinal needle may not be of sufficient length to access the intrahepatic umbilical vein. My favorite site is intrahepatic umbilical vein. When it is not accessible for any reason, then only I go for a placental insertion site. Free loop of cord, I never use. It is a very dangerous situation, and if you miss it, then invariably you lose the baby. This is something you prepare the trolley. This is how this patient is about to undergo the procedure, and here I have put the needle, and you can see the blood which is being aspirated for testing before starting the transfusion. While you are doing all this, you have to use the ultrasound machine. I have an ultrasound machine with a color Doppler in the OT, which I use for the intrauterine transfusion. The advantage of the color is you can monitor the middle cerebral artery velocity during the transfusion, and you know the adequacy of the transfusion there and there only by looking at the middle cerebral artery velocities. There are the way is you do the pre-transfusion hemoglobin, you do the post-transfusion hemoglobin, and then you check. Your target is always a hematocrit of about 50%, but not that always you achieve this target, especially for the first transfusion. Maybe you will have to be happy with the 35 to 40 hematocrit is even good, and then subsequently you plan. Subsequent transfusions are planned at about, first transfusion is planned at 1 to 2 weeks, and usually once the hematocrit is achieved 50% or so, maybe 3 to 4 weeks is the usual interval required in a moderate to not very severe anemic fetuses. But those who are very severe may require frequent transfusions, especially between the 20 to 28 weeks. The frequency usually is required more, because these are the fetuses who tolerate small volumes. If you try to put more volume, usually they'll end up in cardiac arrest and will lose the baby. So you have to be very careful. With the 21 to 26 weeks is a very difficult time to go through when there is a early sensitization. Amount to transfuse, there are various formulas which are, there is a coefficient method is there. Then this is a the one which I use, a V transfuse is equal to V placenta fetal into difference between the final hematocrit and the initial hematocrit, followed by the hematocrit divided by the hematocrit of the transfused blood. This is a guideline, how much volume to transfer. We don't stick to this volume. It always depends. Every fetus has a different capacity. There are some fetuses where we have seen that before, they may not reach this much calculated volume, and they would start developing bradycardias and those kind of things, where we have to stop, or we have to abandon the procedure and repeat it after some time, a few days. For the, as I was telling about early hemolytic severe disease, there are different ways, which different treatment modalities which are available. One is a try to do a artificial AID, donor insemination, with a negative donor. Second is a surrogacy. Third is you can do a PGD in case of a heterozygous husband. If the husband happens to be heterozygous for RH, you can select a negative fetus, negative embryo, and put it in the embryo transfer. Then there is one very expensive treatment, plasmapheresis. It is being described, it is practiced in the Western world. We don't have that access, and it is a very expensive treatment. And IV immunoglobulin, you know, it is also a costly affair, because you have to give it in a dose of 1 gram per kg, and it comes to about 50 grams. So the cost goes in lakhs of rupees, and that you have to repeat every week. So it is just to complete the list. We don't have those kind of luxury, that kind of luxury to do all those things. Now, here is something which is there on the horizon. This is called the FcRn receptor blockade, blocking agents. Now, FcRn receptors are the receptors which degrade the IgG and albumin in the lysosomes. If you prevent this IgG and albumin going into the lysosomes and the placental trophoblast, then those antibodies would not pass to the baby. Those will be blocked at the level of placenta. And this is a drug which is being now tried. It is now in the phase 2 trial. This is in the phase 1 was in 2019. Now it has gone into the phase 2 trial. The name of the drug is something starting with the V. I don't remember now. So these are kind of monoclonal antibodies which are being used. And if this comes, probably even intrauterine transfusion would become a history after this drug comes into the practice. Thank you.
Thank you, Dr. Ajit Gandhi, sir, for that insightful presentation. We are truly grateful for sharing your valuable insight. Next topic is felicitation. I request Dr. Raju Dabde, sir, to felicitate Dr. Ajit Gandhi, sir. Lecture. Next topic is by Dr. Sumit Chamriya on soft tissue marker. Please, sir, go ahead with your topic. I request Dr. Umbardan, sir, please felicitate Dr. Sumit Chamriya, sir.
नाही इकडे आहे ना माझं हां येस येईल येईल ते फक्त वर खाली केलं होतं नाही तर पेनड्राईव्हर आहे माझं बघू माझं एकदम क्लियर इथं पेन ड्राईव्हवर पण आहे का पेन ड्राईव्हर आहे मी सांगतो जस्ट इन केस
डबल डिस्प्ले करायचं डुप्लिकेट नाही आहे ऑप्शन
मल्टिपल जाऊ
ये घे थँक्यू Okay, so now we are going to have a talk on ultrasound soft markers for aneuploidy, a very common thing which we see in our day-to-day practice. Are they actually soft markers or they hit us hard? So why this presentation? Because often we get the scan report which says that there is a single live, means when we send a patient for an anomaly scan or a TFA scan, that there is a single live intrauterine fetus of 20 weeks. There are no obvious anomalies seen at present, normal Leica, normal Dopplers, but at the end there is one line which says that there is an intracardiac echogenic focus in the heart with query significance. Or some other patient, we have a last line which says that there is a choroid plexus cyst in the brain. Or some third patient, we have the last line saying that there is an absent nasal bone, which is a query marker for aneuploidy. So how do we go ahead when we have these markers on scan? What next to be done? We will see in subsequent slides. So what's an aneuploidy? We have seen through the day today that aneuploidy is any abnormality in the total number of chromosomes in a cell. So for human beings, aneuploidy would be any number of chromosome other than 46. For trisomy 21, that's Down syndrome, the number of chromosome is 47. For trisomy 18, Edwards syndrome, the number of chromosome is 47. Similarly, for 13, that is Patau syndrome, we have 47 chromosomes, while in monosomy X, that is the Turner syndrome, we'll have the number of chromosomes to be 45. That's as simple as it is. So this is a karyotype report or a ideogram of Down syndrome case where we see that amniocentesis was done and the KT shows that that 21 number chromosome has 3 chromosomes. So it is a case of a pure trisomy 21. Here in the case of Edwards syndrome, we see there are 3 chromosomes on 18th, so it is an Edward. And similarly, for a Turner syndrome, we have a single X chromosome, so it's a case of monosomy X. So what are soft markers per se? So these are minor ultrasound findings which are identified in the first or the second trimester of pregnancy. They do not represent a structural anomaly and maybe a normal variant. Why are they important? Why are they noteworthy? Because of their association with an increased aneuploidy risk. So soft markers in first trimester, Sripad sir also discussed in the morning, the increased NT, hypoplastic or anossified nasal bone, tricuspid regurgitation and A-wave reversal in DV. What we are going to discuss today are the second trimester soft markers that we see frequently on an anomaly scan. That is the isolated echogenic focus in the heart, choroid plexus cyst, the single umbilical artery, echogenic bowel, mild renal pelvis dilatation, that is mild pylectasis, aberrant right subclavian artery, increased nuchal fold thickness, and an unossified nasal bone found on second trimester scan. So before we move on to the actual discussion, let's have one spotter. Here we have an image of a fetus which had 4 soft markers: the aberrant right subclavian artery, the unossified nasal bone, echogenic focus in the heart, and mild dilatation of the kidneys. So There are multiple markers in this baby. So this is a straightforward case where we need to do an amniocentesis to rule out trisomy 21, and indeed the trisomy 21 was found on amniocentesis. So we are not going to discuss such straightforward cases. We are going to discuss the cases wherein we find an isolated single soft marker. So what is an isolated soft marker? The term isolated is used to describe the soft marker when identified in absence of other structural anomaly. There should be no growth restriction or IUGR, and there should be no other additional soft marker following a detailed obstetrical ultrasound examination. So going on to the first soft marker, the most common one which we see is echogenic intracardiac focus. What it is, how do we define it? It's a small, less than 6 mm echogenic area in either ventricle of the heart, which is as bright as the surrounding bone. What exactly it is? It is just the microcalcification of the papillary muscle of the heart. Can be single, can be multiple, and can even be in one or both the ventricles. And these echogenic focus are identified in up to 25% of the women of Asian population. These are few of the images. The first one is a normal 4-chamber heart. Here we see the 2 atria, the 2 ventricles, and the ventricles are normal. Here in the second image, we can see that there is a single echogenic focus or a tiny white dot in the left ventricle of the heart. Why do we call this as the left ventricle? Because this is the spine here, left ventricle of the heart. The third image, we can see the tiny focus in both the ventricles of the heart, while the last image is of the 2 foci which are in the left ventricle of the heart. So we have all the 4 combinations. You can have either a single echogenic focus in the left ventricle. Echogenic focus is seen on a target scan. For patients with negative aneuploidy screening, that is if they have undergone a first trimester screening test and we find an isolated echogenic focus, there is no need for a fetal echocardiography. There is no need for a follow-up ultrasound just to look for the echogenic focus, whether they are increasing, decreasing in size. We need not do an invasive test like amniocentesis solely for this indication. And there is no need for a postnatal evaluation of the focus by doing a postnatal 2D echo, because EIF or the echogenic foci are not associated with cardiac malformation in the fetus or the newborn. Meta-analysis from 2013 has demonstrated that there is demonstrated lack of association between the isolated EIF and trisomy 21, and the positive likelihood ratio is in fact less than 1. So there is lack of association between the EIF and the trisomy 21 when it is isolated. Moving on to the second soft marker, choroid plexus cyst. What is choroid plexus cyst? Small fluid filled structure within the choroid of the lateral ventricle of the brain, usually are less than 10 millimeter in diameter. Choroid plexus cysts are seen in 1 to 2% of the euploid, that are the normal fetuses in second trimester. So when it is seen in normal fetuses, why are we concerned? Why are we bothered? Why are we worried about this CP cyst? Because CP cysts are seen in up to 30 to 50% of the fetuses with Edwards syndrome, that is trisomy 18, and hence a detailed anatomical evaluation at target scan is of utmost importance. Presence of CP cysts, they do not alter the risk for trisomy 21, that is the Down syndrome. Again, a very important point. Presence of CP cysts, they do not alter the risk for trisomy 21. So here we have a normal lateral ventricle where we can see a CSP, the lateral ventricle with choroid plexus snugly fitting in the lateral ventricle. Here we can see that the choroid plexus is showing a cyst. And in the third image, we can see the choroid plexus cyst to be present on both the sides. So what next to be done when we have a CP cyst on the target scan? As we discussed previously, CP cysts are seen in 1 to 2% of the euploid fetuses in second trimester as an isolated finding. So if isolated, then reassurance of the couple is recommended. CP cysts, they usually regress spontaneously in 99% of the cases by 28 weeks pregnancy. So in our growth scans, we are unlikely to see them again. And postnatally, neurocognition, motor function or behavior of these fetuses or the newborn after the delivery is normal. So this line helps us in counseling of the patient, because anything related to heart or the brain, the patient gets freaked out or gets too much worried. So this last line is important for counseling of the couple, that there won't be any neurocognition or behavioral problems in these babies post-delivery. Moving on to the third marker, single umbilical artery. Normal umbilical cord has two arteries, one vein, all of us knows. In cases of single umbilical artery, it either results from the atrophy or the agenesis of one of the single pregnancies, or up to 4.6% of the twin gestation. And single umbilical artery is associated with increased perinatal mortality, increased chances of IUGR. These are few of the images. First we can see the Mickey Mouse sign, where we have the two arteries and one vein. Here is the case of a two vessel cord, where we can see one artery and one vein. This blue image is of a twin pregnancy. This is the intervening membrane in between. Here we can see a three vessel cord, but here we have a two vessel cord. So one of the fetuses had two vessel cord, another had a three vessel cord. I was lucky enough to get this image in one go. A better way of seeing the for the single umbilical artery or the three vessel cord is to do the color Doppler around the bladder of the fetus. When we put on the color Doppler, and if we see the umbilical arteries emerging from either side of the bladder, we can be rest assured that it is a three vessel cord. As against, when we have a single umbilical artery or a two vessel cord, one of the side won't be having the blood vessel, that is umbilical artery, arising from the side of the bladder. So what do we do next when we have a single umbilical artery at anomaly scan? Go through the images again. Very important. Anomaly scan, you find that it is a single umbilical artery. Keep the eyes open. You have to do a very good anomaly scan. If the cardiac views are adequately visualized and are normal, you are confident you have done a good work for the heart, then fetal echo is not routinely warranted. Otherwise, one can go ahead for a fetal echo. Isolated single umbilical artery, no additional evaluation for the aneuploidy is needed. What is suggested then in such babies or such fetuses? Follow-up imaging, third trimester ultrasound for growth, and postnatal complete clinical evaluation by pediatrician to rule out occult anomalies is needed in cases of single umbilical artery. Moving on to the echogenic bowel. How do we define echogenic bowel? Echogenic bowel is one when the bowel displays echogenicity equal to or greater than that of the surrounding bone, typically the iliac wing. Before we discuss the echogenic bowel in detail, one important point is a false positive finding can be noted with the high frequency probes. These days, every one of us have a higher end machine. So echogenic bowel can be falsely diagnosed when we are using high frequency probe. So never report echogenic bowel by a transvaginal examination probe, because it's a high frequency probe or other high frequency probes. So here we have the images. Here we can see that the echogenicity of this area is almost equal to the bone which we see. And in the second case also we have the echogenicity which is increased or as compared to that of the spine. So when do we get the echogenic bowel? Echogenic bowel is actually associated with a wide range of pathogenic conditions like aneuploidies. We have cystic fibrosis, although it's not common in our country, congenital viral infection, the TORCH group, primary GI pathology, if there was an intraamniotic bleed with subsequent swallowing, and fetal growth restrictions. So echogenic bowel in aneuploidy, the Down syndrome, the estimated incidence of echogenic of aneuploidy in the fetuses who have echogenic bowel ranges from 3 to 5%, with Down syndrome being the commonest one. Now, why do a baby of Down syndrome have echogenic bowel? So what has been proposed, the pathophysiology is that there is a mechanical or functional bowel obstruction in these fetuses which causes hypoperistalsis. leading to dehydration of the meconium and increased echogenicity of the bowel loops. So what next if we have a isolated echogenic bowel at anomaly scan? Thorough history regarding the viral illness, whether she had fever in the past few weeks is important, whether she had history of first trimester bleeding is important. On scan, re-look for subtle anomalies, re-look for the growth restriction. Torch test, IgG and IgM titers for viral infections are needed. For aneuploidies, if the first trimester screening is negative, then it's fine. Else, we need to counsel them regarding the probability of trisomy 21 and option of NIPS versus invasive should be given. So let's revise the first 4 markers which we have seen. Echogenic intracardiac focus. Meta-analysis has showed us that there is lack of association between EIF and trisomy 21. So no aneuploidy testing, no echo. I know from tomorrow I might get a less number of echos which were being sent for EIFs, but doesn't matter. No echo if one is confident about the cardiac. Second we saw is CP cyst, regresses spontaneously, no aneuploidy testing is needed if it is isolated. Third one was single umbilical artery, a good anomaly scan is enough. A good anomaly scan is enough, absolutely no need for aneuploidy testing or invasive testing for single umbilical arteries. And yes, for echogenic bowel, obtain a detailed history, narrow down to the possible etiology and work up accordingly. Moving on to the aberrant right subclavian arteries, something which has come up in last 1 decade, unusual pattern of right subclavian artery it is. It is associated with trisomy 21, DiGeorge syndrome, seen in 1.5% of the euploid general populations. Difficult slide to understand, let's make it simpler. This slide shows us the normal neck vessels where we can see the first branch is the brachiocephalic artery which divides into the right subclavian and the right common carotid. Second branch is the left common carotid and third branch is the left subclavian artery. What happens in cases of URSA is instead of dividing here, this marker as well, instead of dividing or coming up from the first branch that is the brachiocephalic artery, the right subclavian artery comes as the 4th branch, 1, 2, 3, 4th branch and goes behind the trachea and goes to the right arm. So that is the aberrant course of the right subclavian artery. So what do we do if we have an aberrant right subclavian artery which was noted at the target scan? For aneuploidies, if the first trimester screening is negative, again no need for further testing. If no previous testings were done, we can counsel them about NIPS, quadruple marker test, and no need for echocardiography, echo per se if the finding is isolated and adequate cardiac imaging has been done. Again, mild renal pelvic ectasis, we measure it in the anterior posterior diameter, is a most common, it most commonly is a transient finding, but may be an indicator towards a evolving genitourinary obstruction. Why are we concerned about renal pylectasis in Down syndrome cases? Because around 10 to 25% cases of the Down syndrome babies may have mild renal pelvic-ectasis. More important in pylectasis is to correctly measure the renal pelvis dilatation, which should always be done in the anterior posterior diameter. The first image is the coronal section, in which we are not going to measure the renal pelvis diameter. We are going to always measure it in the axial sections. So mild pylectasis on target scan, what next? Positive likelihood ratio is low. So patient with a serum negative screening and isolated pylectasis, no further aneuploidy screening is needed. What we need to do is just evaluate for the persistence of the pylectasis on serial scan and third trimester ultrasound to determine whether there is any postnatal pediatric urology follow-up needed. Sometimes you may have something called evolving uropathologies. VUR is there, and also we need to see PUJ, VUR and all we may have. So just a follow-up scan is needed. Thickened nuchal fold, one of the first identified markers. In fact, when Down had described, the one of the markers which he had described was the increased nuchal fold or increased thickness of the skin behind the neck. So increased nuchal fold is one of the first identified ultrasound as well as the physical marker for trisomy 21, and it is one of the most specific marker till date. How do we define it? It's a thickened nuchal fold more than 6 mm between 15 to 20 weeks of gestation. And the positive likelihood ratio is 11 to 12 fold, but we cannot measure the nuchal fold in this image, in this section. We need to have a transcerebellar plane in which the nuchal fold has to be measured from outer to outer. So this is the actual images in which we have to measure them for the probability of trisomy 21, and the discussion for NIPS or amniocentesis should be made because of the high likelihood ratio. If the fetus is euploid, serial scan for evolution is not needed. If cardiac anatomy is well visualized, echo per se is not indicated. Absent nasal bone, we have discussed in the morning. We had images by Dr. Ashwini where she had explained us how to examine a nasal bone in the profile view. Here we can see in the first image the nasal bone is very well seen, while in the second image we see that there is total absence of the nasal bone. So unossified nasal bone, it's a significant marker. So unossified nasal bone, it's a significant marker. So when unossified at 20 weeks, we need to counsel them about the probability of trisomy 21, and option of NIPS or amniocentesis should be provided. If the fetus is euploid, serial scan for nasal bone measurement or ossifications are actually not needed. Again, we'll just revise the last 4 markers which we have seen. Aberrant right subclavian artery, low likelihood ratio for trisomy 21 when it's an isolated thing, so no need for echo. Second, renal pylectasis, soft marker with low likelihood ratio, just follow-up scans for the evolving obstructive pathologies. Nuchal fold thickness, sensitive marker, specific marker, needs action, amniocentesis, better if not at least NIPS. Absent nasal bone, again sensitive marker, counsel for NIPT, amniocentesis, get it done is needed. Another soft markers, we have mild ventriculomegaly. There are multiple reasons for it. It can just be a normal variant, can be because of trisomy 21, can be because of infection, the torch group, can be a marker for evolving obstructive hydrocephalus. Similarly, short long bones like short femur or short humerus, it can be a normal variant, can be a pointer towards evolving skeletal dysplasia, chromosomal disorder like trisomy 21 or IGR. So better to involve a fetal sonologist or a fetal medicine consultant in such cases. Few markers which are actually minor, clinodactyly, that is the curved little finger, or sandal gap toe, or widened iliac angle, shortened ear length, short 5th digit. These are frequently seen in normal fetuses also. There are a few papers which have described them, but they should not be used in isolation to detect the fetuses with trisomy 21. Thank you.
Hello. Thank you, Dr. Sumit Chamria, sir, for acknowledging us on soft tissue markers. I request Dr. Priya Bhinge, ma'am, to come on the stage to felicitate chairpersons.
Hello, ma'am.
Hello. Thank you, ma'am. Thank you for the beautiful session. Now, a few people have to go for an emergency, so we'll be continuing with the next session and we won't be stopping for lunch. So kindly bear with us. We'll begin with the next lecture.
Moving on to next session, now I invite Dr. Meenal Agarwal, madam, to give a lecture on genetics. Genetics in reproduction.
So you can just click here.
Dr. Meenal Agarwal, madam.
That's it. I'll do. Thank you. Thank you very much for the kind introduction. And thank you, organizers, and thank you, my audience, to be with me during and post-lunch session. My previous speakers... Okay.
I invite Dr. Varsha Kane, madam, for chairing. Dr. Piyush Gadam, urologist, Pandharpur. Dr. Bangar, gynecologist from Sangola.
Thank you, chairpersons, to be here. So thank you, my audience, as well. And as I was saying, my previous speakers have made my job very, very easy. Many of the things and most of the things have been covered in one or the other way in the previous lectures. So what I'm going to do a recap and reinforce on the important things which we need to take as take-home messages. Since our MBBS days, undergraduate days, we have always happened, but it gives them an answer. This many cases it provides us the diagnosis for management, associated complication, and how the child has to be followed. And of course, this is an era of genetic counseling. It is an essential part of an infertility prenatal, as we have been hearing since morning. There are so many things which can happen in a child. And most important in today's world, this is a medico-legal implication for all of us, and that's why we need to be aware about this. So obstetrician intersect with families at every stage, from preconception to prenatal and postnatal. In fact, even if the child is not growing well, many a times they do not go to their pediatrician, they come to the obstetrician and say, you have delivered my baby, and you have said everything was normal, now what has happened? So obstetrician are the main contact points for all reproductive problems, and we all have to be aware about that. So this is a very recent example. As I was talking about a Gen Z couple in IT industry. They wanted to get married. They were first cousin, and which is not very uncommon scenario in Maharashtra and South India. They wanted to get married, and they were worried about their child getting of any kind of genetic illness, and they want to know everything about their child. In fact, they are not even married. And they came with both sides of parents for genetic counseling. So there were 6 people in my counseling session, 2 parents from this side and 2 parents from this side. So before I could start for my genetic counseling session, I need to explain why the genetic disorders arise. We need to understand that each one of us has millions and billions of cells. And each of these human bodies is arising from a single cell, that is zygote, and which is formed by the union of 2 cells, sperm and egg. And it is not necessary that genetic disorders are passing on from the sperm or the egg. In fact, most of the genetic disorders arise in those families where everything has been normal, because at the time the sperm and the eggs are meeting, 23 chromosomes from each side and 25,000 genes are coming from each side, and error can happen then and there. And then that's why about 2 to 5% of every live-born child has a chance of having a major genetic abnormality. And this chance is much higher in early conceptus. And now the pre-implantation genetic testing in IVF embryos, they have taught us that up to 50 to 80% of each conceptus has chromosomal abnormalities, and despite having a normal family history. So this is important. So what is my counseling? So every 2 to 3, even if the family history is normal, there is a 2 to 3% chance of child having a genetic abnormality. This chance is slightly increased, only slightly, when there is a consanguinity, there is a marriage between relatives. It means there's a 90 to 95% chance that your child is going to be normal. So rather than the bad part, I would rather reassure them, okay, this is a major chance that your child is going to be normal. I'm going to take a detailed family history because if there is a consanguinity in the family and there is a history of a genetic disorder, this chance of 5 to 7% of abnormality may straight away increase to 25%. And that may change the counseling significantly. I talked about the background risk, even if everything is normal and there is nobody in the world which can guarantee a 100% outcome. And that is what, when you say it is normal. So whatever can be seen has been seen and is normal, but something cannot be seen. The second, we have to talk about the random event which can happen in every pregnancy, which we are hearing since morning, like Down syndrome, like aneuploidies, like major malformation. Usually these are random events, and many of the times they do not recur. But every pregnancy is at some risk. And third, we have to offer them screening for common condition, as Dr. Datar was talking in the morning, for beta thalassemia. So every couple who is planning pregnancy and even in the early pregnancy, carrier screening for thalassemia has to be offered. There are some more diseases which I have added to the list, SMA, CAH and DMD. There are no consensus, no guidelines, but if the couple can afford, we need to talk about it. And then, because they were first cousins, they were keen, they were Gen Z, they were Googling, I had to offer them a very advanced testing by a whole exome sequencing where the 25,000 genes will be matched against each other, and we will see that if they are a carrier of a common genetic condition. So it was detected that Ramesh and Sudha, they are the artificial names, they are not the real names. They are carrier of a gene in the TGM1 gene out of those 20,000 genes, though both were carrying the same genetic defect because there's a consanguinity, and this is associated with congenital ichthyosis. There is a skin thickened, there's a lot of neonatal infection, and this is a serious baby. And because this is a autosomal recessive disorder, one copy of the abnormal gene can come from each parent, like thalassemia, there is a 25% chance of recurrence. Couple married, within 6 months they got pregnant. We offered them a prenatal diagnosis by chorionic villus sampling, and the fetus turned out to be normal and not carrying this variant. Okay, continue pregnancy, but at 22 to 23 weeks, there was a cardiomegaly in fetus, and which was unrelated to TGM1. And if I had not counseled the couple before, probably they would have sat on my head. Oh, you had said everything is normal, you have done my invasive testing, and it's still something. This is a random event. So, because at the time of invasive testing, we had offered them a microarray as well as a routine protocol to look for Down syndrome and other deletions and duplications. And that's why we said, okay, nothing doing more, we can just see for an evolving anomalies and we keep the baby for the follow-up. So this is an everyday example when there is an IVF pregnancy going on, they are going for a donor egg, donor sperm, and they say, okay, screen the donor significantly and appropriately. We do not want any genetic disease in my child. And that's why we have to document, we have to counsel, and then we have to document the counseling. That is what is more important. So we have already spoken, Dr. Datar already spoke about it, that what is a genetic architecture? When we talk that what is genetics, so each one of us is made of millions and billions of cells, and that is originating from a single cell, okay? And in each cell there are 46 chromosomes, 23 come from each side, and on each of these chromosomes you can see white and black lines. So a simple karyotype can look for only the numerical change. One chromosome is extra or one chromosome is missing, like Turner syndrome when X chromosome is missing, or a Down syndrome when 21 chromosome is extra, nothing beyond that. It cannot see anything else. But there are white and the black lines which can be seen under testing, which is called as microarray. And if you stretch these chromosomes, if you stretch this DNA, this is a string of alphabets. And how many alphabets? 6 billion alphabets. And if you have to look for a mutation in thalassemia or a single gene disorders like DMD, you are looking for a single alphabet change in the entire 6 billion alphabet change. And that's why what Dr. Datar said, that workup of these families and these couples are important in the preconception phase and early pregnancy, not during the pregnancy because we don't have enough time. And as we have already speaking, the amniocentesis in CVS is just the procedure of collecting sample. And what tests we decide to do in that sample, that is another thing. All kinds of DNA tests, they start from the sampling. So amniocentesis and CVS is just the sampling. And what kind of test we decide depends upon lot of things. And you can imagine in your head is like a camera. So if you are using a low resolution camera, you can see a panoramic view. It will give you just the idea what is going on. But if you want to go inside, further zoom in, then you probably get an idea what is that alphabet change in out of that 6 billion alphabets. And based on that, based on what type of abnormality it is, whether there is consanguinity or not, you choose one of these tests, and that is important. So coming on to the most important topic in a genetics and reproductive world, that is reproductive failure. It means inability to take a pregnancy to term, and it is one of the most common scenarios in my clinical practice. And it is a continuum, as you all understand, whether it is subfertility, whether it is miscarriage, whether it is intrauterine death, an abnormal baby, unsatisfactory outcome, couples are equally perturbed and they need an answer. And whether there are many different classifications, but genetics intersects at every level, from subfertility to IVF failures to early pregnancy loss, late pregnancy loss, stillbirth, neonatal complication, abnormal outcome, genetics intersects at every level. And you can see in red, okay, that the type of test which we are offering in an early pregnancy loss or a couple dealing with infertility is very different what we are offering to a neonatal complications. And that's why the preconception and early pregnancy, the first meeting with obstetrician is very, very important to take the history in detail, to figure out what kind of test they need, and if they do not have any family history, at least offer them preconception screening for common conditions like thalassemia. So coming on to infertility, so we know that 10 to 15% of reproductive age couple, they deal with subfertility. And somebody was asking the type of test in infertility. First and foremost is the karyotype abnormality. And what we are looking for in karyotype, in a male infertility, we are looking for mainly sex chromosomal aneuploidies, the Klinefelters, and something which is called as balanced chromosomal rearrangement. And I will talk about in a minute. And this is found in about 2 to 5% of the couple. Many of the male infertility, in fact, up to 10 to 15% of male factor in subfertility is caused by chromosomal factors. If not numerical, there is a balanced chromosomal rearrangement. It means there are 23 pairs of chromosome, and one part of the chromosome has gone and attached to some other chromosome, or it has changed its position. So overall, everything is balanced. No gene is lost, no chromosome is lost. But when this man is making sperms, there is an abnormal segregation of DNA material. I'll talk about in a minute. This couple came to me after 2 IVF cycles failed and they were perturbed. They wanted to know, and there was a translocation which is written in red between 2 and 17. And you can see that chromosome 2 is little shorter, and the chromosome 17, where in the image is the arrow is, 17 is little longer. Another example where there is an inversion, the piece of the segment of the chromosome is there, broken at 2 places, inverted and attached. This is another type of chromosomal rearrangement which you find in a couple with infertility. But remember, not all chromosomal inversions are abnormal. For example, chromosome Y, chromosome 9, and chromosome 16. These pericentric inversions are supposedly a normal chromosomal variations. They are not associated with significantly abnormal. When I'm saying significantly abnormal, it means there may be an anecdotal reports where they say, okay, pericentric inversion may lead to abnormality, IVF failures, and so on and so forth. But generally, there is no significantly increased incidence of reproductive failure. Second important test which we have to do in infertile couple, especially in the case of asthenozoospermia, is a Y chromosomal microdeletion. Because you can see Y chromosome in a karyotype, but on those white and black lines, you cannot see whether the subpart is deleted or not. And that will lead to a asthenozoospermia. Important thing for counseling is, even if you can take out few sperms by TISA, all those Y chromosome will be carrying this microdeletion. And all their sons are going to be infertile. And that is what is important during a counseling session, because you are making the zygote with the same sperm, same Y chromosome, and same microdeletion. So if The person, male member, is having a male infertility, having an asthenozoospermia, get a Y chromosomal microdeletion, which is different from karyotype, which is a blood-based test, does not cost much, maybe up to 5,000 to 7,000 per sample, not much. But beyond this, if somebody is suggesting genetic workup beyond karyotype and Y chromosomal microdeletion, I would say take an opinion from a genetics professional. You can talk to the laboratory, and most of the laboratories, they have a tie-up with a clinical geneticist, and you can figure out what type of test is better for them. From infertility, we move on to miscarriage. In the previous slide, I have shown that up to 50 to 80% of conceptors are chromosomally abnormal. In fact, most of the miscarriages, about 90% of them, are caused by a chromosomal abnormality. In these cases, none of these abnormalities is being passed on from the sperm and the egg. This is a random event which is being generated at the time of fertilization. Welcome, ma'am. Welcome, ma'am. So in 90% of early miscarriages, the cause is chromosomal abnormality. Until about 5 to 7 years back, the karyotype was the test of choice. But the karyotype requires a culturing of cells. Like you sow seeds, you put water. Some of the seeds grow and some of the seeds do not. And that's why the chances of the failure of a karyotype is very high. In fact, in about 50% of the cases, even if the patient is paying money, the laboratory will not be able to give you results. In those scenarios, the MLPA and microarray, it's test of choice if you want to know the cause of abortion. But my question is, do we really need it? Because as I said, this is a very common event. 50 to 80% of early conceptors are randomly lost in miscarriage. 90% of all miscarriages are caused by chromosomal abnormality. This is a fact. But what we are achieving by doing that? Absolutely nothing, apart from giving a satisfaction to the parent and the couple, okay, this was not my fault, this was something genetic. So actually doing a genetic testing on abortus does not give you any significant information. In fact, if the couple is having 2 or more than 2 miscarriages, couple karyotype doing makes more sense rather than doing an abortus karyotype or microarray, because this will give you information about balanced chromosomal rearrangement, which is associated with significant risk of recurrence and reproductive outcome. So if your family is dealing with 2 or more miscarriages, couple conceptors is not a method of choice unless and until they are very anxious, they want to know the cause, they want to spend money, they have money to spend. But more than that, the workup of the couple for balanced chromosomal rearrangement, workup for maternal medical condition, and antiphospholipid syndrome are the 3 things that should not be forgotten. Don't jump on a genetic testing on abortus. Something can be done doesn't mean it is helpful. So we need to figure out what is the most cost-effective test for the couple. So coming on to a little bit on this balanced chromosomal rearrangement. So what happens, so in this you can see a normal chromosome 2, which is in pink, and a normal chromosome 9, which is in purple. And the other pair is a balanced chromosomal rearrangement where pink has gone and attached to the purple, and purple has come and attached to the pink. So this is a rearrangement, balanced chromosomal translocation. So everything is normal and balanced in this family, in this person. Pink is complete, purple is complete. But when they are making the eggs or sperm, pink tries to pair with pink and the purple tries to pair with pink because of the exchange of materials. And in that manner, there is a 30 to 50% of chance that an abnormal gamete is being formed. Either pink is more or purple is more, pink is less and the purple is less. Imagine one of these dark line or light line is carrying 100 to 1,000 genes. Thalassemia is caused by a single alphabet change in a single gene. And imagine if hundreds of genes are missing or hundreds of genes are extra, what is going to have this conceptus? So there is a significantly high chance of miscarriage, up to 30 to 50%. And even if this pregnancy does not end into miscarriage, there is a high chance that ultrasound may detect malformation. And this is a typical indication for doing a direct amniocentesis without offering an NIPT, without offering a dual marker test. This cannot replace an NT scan though, but this is a straight indication for doing an amniocentesis because you are looking for chromosomal abnormality other than trisomy 21, 18 and 13. So there is no point of NIPT in this case. This is a message I want to tell. There are so many labs coming up and somebody is offering you the same karyotype in 3000, somebody in 2500, 2000, 1000, 1500. So in the first image, this karyotype is showing the translocation from 7 to 7. It means the chromosome 7 part is translocated to chromosome 7, which is wrong. There is no nomenclature like this. I'd simply ask the person to repeat the test from a accredited laboratory, and this is a centric inversion. This was an inversion of the chromosomal segment, and that's why the message is select your laboratory partner very, very carefully. Do not go after the lowest rate. This might not be true. Coming on to a couple of slides on prenatal diagnosis, and we have been hearing it since morning. So this is not always to find an abnormality or terminate the pregnancy. Actually, many of the times this is to ensure, okay, whatever can be seen is seen normally. I'm not saying everything is normal, but the thing is whatever can be seen at this juncture is normal. Of course, there is a background chance, but nobody in the world can see that and should see it. So you are within whatever normalcy limit. Okay, and there are two types of diagnosis, non-invasive and invasive, and we have been hearing it, so I will not detail. If you get a high risk for trisomy 21 or if you get a soft marker, of course, there is an indication when to do an amniocentesis and you have been hearing it. But what if you identify an abnormality, what Dr. Ashwini and Dr. Sumit told you, soft markers. So 1, 2, 3. What are the associated abnormality in additional imaging as per Dr. Ashwini? Second, what is the risk of genetic syndrome? So choose an appropriate genetic testing. Again, amniocentesis is a procedure, and what test you choose inside it, that is another thing. So choose the genetic test very carefully, and you have to tell the overall prognosis and outcome. Like in anencephaly, like bilateral renal agenesis, like significant congenital diaphragmatic hernia. If anyways there is poor outcome of pregnancy, probably there is no point in offering amniocentesis then and there. Maybe you deliver the baby, get the autopsy or at least an examination done, and then decide what test is the best test. So probably in those cases, I would rather wait that family terminates or discontinues the pregnancy, look at the fetus, and then decide what is the genetic testing. So this is a typical case of anencephaly, and anencephaly can be a varied etiology. It can be an isolated neural tube defect, it can be a chromosomal abnormality, or it can be a single gene disorder. When I talk about single gene, it should ring a bell in your head because it is associated with 25% of risk of recurrence in most of the situation. So there was no polydactyly, kidneys were normal as were found in Meckel's-Gruber. Postnatal examination had isolated encephalocele. So chance of recurrence is as similar to neural tube defect. Rule out maternal diabetes, and probably no genetic test would be helpful in figuring out what has happened. Nowadays, couple may choose, but generally at an outset, no genetic testing is indicated in this. We have been talking about NIPT since morning. Typically, you have to understand when it's not to be done, and Dr. Datar carefully described it. The only take-home message is, okay, it has a very high negative predictive value, means if it is negative or low risk, there is almost negligible chance to have a trisomy 13, 18, and 21. That's it. These are just 3 disorders out of 5,000 genetic disorders. But still, rarely false positive and false negative have been reported, and that's why you cannot stamp on the paper that there will be no trisomy 21. Of course, during counseling you can be candid and tell them, but your documentation should say this. Though this is having a 99% negative predictive value, but rarely false negative cases has been reported. And this is a limited use when there is a history of genetic disease in the family, ultrasound detected malformation, presence of multiple soft markers, and of course it has to be associated with pre-test and post-test counseling. Cytogenetic microarray and exome sequencing are the advanced tests which are being offered in amniotic fluid because of the various indication. And my suggestion would be, if you are dealing with a malformation, at least talk to a person who is dealing with these areas. Talk to a fetal medicine expert, talk to a geneticist regarding this, which is the best test. Coming on to the postnatal problem, Dr. Datar already spoke about a couple of cases in autopsy. In 80 to 90% of the times, it confirms the finding of antenatal ultrasound, but in 5 to 10% of times, it gives you a subtle hint what can be the cause, and it helps you in taking out the appropriate test. And we spoke about the autopsy, but sometimes the only thing helps is just the photographs. So this is a second gravida, previous stillbirth, and the husband had the photograph of the fetal face in his mobile, and this is the typical face of Down syndrome. And this, most of the times it is caused by a free trisomy 21, which is not associated with a significant risk of recurrence. I would take a minute to describe what is free trisomy 21. So if there are 3 chromosome 21, it can be free floating in the cell. It means it makes 47 chromosome instead of 46. But in 10 to 15% of times, it may be attached to some other chromosome that is a translocated chromosome. So if there is a translocated chromosome 21, the risk of recurrence may range from 15% to 100%. So if you have a fetus, if you have a child with Down syndrome, get a karyotype done if possible, because if you have to ensure that 3 chromosome 21 are lying free, there is a free, because if chromosome 21 is attached to some other chromosome, the risk of recurrence can be as high as to 100%, because there are cases of 21 to 21 translocation. So just the message is, if you have a fetus or a child with Down syndrome, do not just stop on FISH, do not just stop on QF, PCR or microarray. Try to get a karyotype, and if not possible, then parental karyotype, because it will show you if they are carrier for balanced translocation or not. Another child, this is 20 weeks terminated pregnancy. I'm not sure how many of you are appreciating in the fetus case, there's a short limbs, and the fetus is looking like a small case of achondroplasia, like the dwarves in a circus. But achondroplasia will not present at 20 weeks, they will present at 28 or 32 weeks. So this is a very similar disorder, which is thanatophoric dysplasia, caused by same gene but different effect. So just looking at the fetus, taking a photographs, preserve it, that is what is important. Another case, holoprosencephaly. And again, like other condition, holoprosencephaly can have varied etiology. It can be trisomy 13, it can be a single gene disorder, but sometimes it is inherited. It means one of the parent is having a single incisor tooth instead of 2. And that parent is a carrier for a mutation in holoprosencephaly gene. And in those cases, the risk of recurrence is 50%. And that's what you need to understand. Whenever you see an abnormality, talk to an expert. And if you're an obstetrician delivering an abnormal or a stillborn baby, write notes, take photographs, collect samples, take a consent for fetal autopsy, and so on and so forth. Last 4 or 5 slides. And if you are dealing with a child with developmental delay, now we know that this is just not Down syndrome and cerebral palsy. We need to look at the child, take multiple tests, and still we are able to make a diagnosis in about 40 to 50% of the cases maximum. And nowadays, advanced testing like microarray and next generation sequencing, like Dr. Datta told you about, they are available to help the family and to make the diagnosis. But every child is not genetic, and every child does not require genetic testing. This child came to us as a case of Down syndrome. This is not Down syndrome for sure. And when we did a basic workup, this was a case of congenital hypothyroidism, which could have been picked up by a newborn screening. That is a simple test which is done on day 3 of every baby's life. And if it is picked up, this child would have been prevented to be a case of developmental delay. Another small message, everything cannot be detected even in advanced test. Karyotype, microarray and exome sequencing. Like a case of congenital adrenal hyperplasia, which present with ambiguous genitalia. This will not be diagnosed by any of these tests. There is a very specific test for this disease, and you have to talk to laboratory regarding, or a geneticist or a fetal medicine expert, that what is the best test. Last 3 slides. This is a model story. And this is the crux of the story, that workup of these couples with abnormality should begin preconception, or at least in early pregnancy. So child with developmental delay, no consanguinity, no family. It was a case of tuberous sclerosis. This case I saw about 15 years back, but I'm still in touch with that couple. That time exome sequencing was not available. We had to make a clinical diagnosis and search for the genes and the variants responsible, like you search in a dictionary for a word, for a spelling. So we searched, it was a case of tuberous sclerosis. We did the sequencing of TSC2 gene. We did the parents testing. As I said, not every genetic disorder is hereditary. So this mutation was a de novo mutation, did not come from the sperm and ovum, but had arisen de novo in the zygote. But still there is a very small chance of recurrence, and that's why we offered them prenatal testing and they have a normal child. Last slide. Genetic test for your clinic or for your patients. First of all, it is important. It is a digitalized world, commercial world. People are Googling, people are taking multiple opinions. You need to be aware about this. And ultimately, it is a counseling, documentation, and documentation of the counseling. And that is what is important for your clinic. And keep reading the literature and keep in touch with an expert. Thank you so much.
Thank you, ma'am. Now the topic is open for discussion. Welcome, Dr. Sujata Gundevar, ma'am. Now I request Gundevar, ma'am, to felicitate Dr. Meenal Agarwal, ma'am. I invite Dr. R.M. Zadav, sir, to felicitate the chairpersons. Dr. R.M. Zadav, sir. Now everyone can proceed for lunch.
before that, there is one viability scan if you are suspecting a pathological pregnancy or ectopic, but that is optional, that I don't do in every patient. The second scan is at 20 weeks, which covers almost all the anomalies, including cardiac. The third scan is at around 28 to 30 weeks, which covers the growth and late developing anomalies. And the last scan is between 35 and 36 weeks, when we know the well-being of the fetus, which gives you the approximate weight, the environment of the fetus, the Doppler, so that you are prepared for the any problems which would arise during the labor. That is the normal protocol in a normal risk patient. But then when there is you find that there is some problem, you have to increase the the frequency of scanning. And it depends on the problem with which you are dealing with. Say, for example, now if you find some borderline ventriculomegaly at around 18 to 20 week scan, then you need to follow it, say, after 2 to 3 weeks. And by 24 weeks, we have to do two important decisions. One is whether she needs a termination. Because if you cross 24 weeks, then the legal issues are very complex, and sometimes the patient may not be able to terminate even if it is an indicated termination. So by 24 weeks, we should try to complete the diagnosis, or at least should segregate the patient between whether she requires a termination or she doesn't require a termination. That is how it goes. Suppose if you are finding, there are some late evolving anomalies, like the cardiac anomalies, the critical aortic stenosis, those kind of things you may not, or some renal anomalies like the autosomal recessive multicystic kidney. Those you may not be able to see at 20 weeks, but they would come up later in the pregnancy after 24, 26 weeks. And that is how the 28 weeks, the 30 week scan helps in predicting these late onset anomalies.
Nothing to add.
Thank you, sir, for summarizing that. What a general consensus was there in a recent ultrasound meeting of the DIAS consensus, that whenever you advise ultrasound for the patient, you have to explain that ultrasound at every particular moment is done for different things. We gain different knowledge about the baby at different trimesters. For example, if you are doing an ultrasound around 9 to 10 weeks, we will get 5 things. गर्भ आहे का, किती दिवसाचा आहे, एक आहे का, दोन आहेत, पिशवीत आहे का, बाहेर जिवंत आहे ना. That's all we gain. We do not gain any more knowledge than that, and we have to tell the patient that this ultrasound is for viability and gestational age. For NT, whatever we gather, we have to counsel the patient that this scan is being done for this particular thing, and we have to keep on counseling the patient that everything under the sun cannot be diagnosed by ultrasound. There are few things which cannot be diagnosed by ultrasound, and we have to make sure that the message goes to the patient that these things are being seen in the ultrasound and these things are not going to be seen in the ultrasound. Second question to Sumit is first trimester screening like NT, NB, DV plus biochemical mandatory?
NT scan is mandatory. If you are doing an NT scan, which is including your good NT as per the guidelines, with nasal bone, tricuspid regurgitation and ductus venosus being included in it, you can reassure the patient up to 80-85% ki things are good, with a false positive rate which comes down to less than 5%, 2.5% it comes down if you are including your DV and TR and other heart rate and other things. So scan is mandatory, but the biochemical testing, that is the double marker, and when we add with the NT scan, it is called a combined first trimester screening. That part is not mandatory. We can give them an option that so and so tests are available which will increase your sensitivity from 80 to 93% in the best of the labs, but not a mandatory thing.
Whether NT is mandatory for each and every patient?
Yes, in today's world, if a patient has come, if she is any patient, I would say do a NT scan. But yes, provided that NT scan should be done well. If we don't have a good machine or the technical expertise to do a good NT scan, then might as well skip it. But otherwise, NT scan gives a good deal of information.
Now the problem in the, yes sir, please.
Yes, NT scan has four main objectives. Number one, as I said, detection of aneuploidy. Number two is prediction of preeclampsia. This is not being done consistently. If you do a proper uterine artery Doppler, even a proper uterine artery Doppler without any markers, without anything, you will be able to, it has a positive predictive value of 80 to 90%. And negative predictive value of almost 98, 99%. So if your uterine artery screen is negative, that means you are assured that this patient is very unlikely to develop a preeclampsia. But if you have if you have predicted a preeclampsia, you have a gold remedy, that is aspirin, and aspirin can reduce the risk of preeclampsia, especially the early onset preeclampsia, by almost 50%. The preeclampsia onset will be late, the severity will be late, the weight of the baby would be better, the fetal outcome would be better. So these are all the advantages of doing the just one single uterine artery screen at NT scan. Number third objective is the risk for premature delivery. If you look at the cervix in the first trimester, and if it is below the fifth centile, say the fifth centile value for the first trimester is 2.8. So if you are finding a cervix which is at 2.8, you have to be watchful on this cervix. If the length goes below 2.4, maybe you would require a cerclage. So that is a prediction of preterm labor. And the fourth is, of course, if you haven't done the previous scans, this is the first window where you will diagnose the multiple pregnancies. It's chorionicity. The chorionicity, if you try to diagnose it at a later pregnancy, you will find sometimes some difficulties. If they are of the same sex, if the placenta is fused, sometimes you would make a confusion that whether they are MCDA or DCDA. But at NT scan, you will clearly make out the lambda sign. You will be able to differentiate between an amnion and a chorioamnion. So that is the advantage of doing the NT scan. So many things you look at in the NT scan. You can detect the early anomalies. Almost 50% of the major anomalies you will be able to pick up at NT scan. Say the neural tube defects, anencephaly, nobody would miss. The skeletal dysplasias, nobody would miss. If you are finding a DV reversal and if there is nothing else, you are suspecting that this baby might be having a congenital heart. So you follow that baby and try to get the congenital heart if it is there. So the major congenital anomalies you will be able to diagnose at NT scan. So these are the so many advantages of NT scan if it is done properly. And a good NT scan takes about 10 to 20 minutes to do. If you can spare that much time, if you have a good machine, you do the transabdominal NT plus a transvaginal anomaly, almost your 90% of the job for the pregnancy is done. Your say, काय म्हणतो, बेबीची पत्रिका तयार झाली आहे.
Thank you, sir, for elaborating that. So to summarize on this question, I would say that whenever we order an NT scan, or few of us are doing it NT scan, then we need to educate ourselves and we need to create a demand that when we are sending a patient for NT scan to a radiologist or a fetal medicine consultant or to a fellow obstetrician, we have to look for all these things. And the NT scan, CRL 70, चांगला है, छान है, जो देना है. We have to look for all those images. We have to look for the NT image. We have to look for the DV images. We have to look for the CRL, whether taken properly or not. We have to look for the uterine artery Doppler, cervical length taken transvaginally and properly. So if we, unless and until we create a demand from the center which we are sending the patient for the ultrasound, that we need all these things from your scan, then only the improvement will occur. Because see, quality improvement is an ongoing process. People like us who have been trained almost 25, 30 years ago and who are not going into fetal medicine, who are not doing scans much, then maybe we are not updated to all these things, but we should be updating ourselves and we should be asking from the center where the ultrasound is done that, sir, please, if this has been done, then why the cervical length has not been mentioned, why the NT has not been mentioned, why DV is not there, and something like that. So we need to update ourselves and demand from the person who is doing the ultrasound that, sir, हे का झालं नाही किंवा याचं सिग्निफिकन्स काय आम्हाला सांगा. Am I right, sir?
Perfect.
One more question. You said it in the previous question. My double markers are not double marker high risk है. उसके बाद but the patient doesn't want to go for amniocentesis. Like he says कि मग पुढे गेल्यावर आम्हाला quadruple marker करायचं. So if is there any point in doing this screening biochemical test if one of them is already done, if it is either negative or positive, एकदा double marker positive किंवा negative आल्यानंतर परत quadruple marker करण्यात काही significance आहे का?
When we do a double marker, it is always it's a combined first trimester screening. First and foremost, we have to understand there are two concepts. One is double marker, one is combined screening. Double marker per se is only 55% accurate if you are not including your NT-NB things. So double marker is not the test. We are talking about the combined first trimester screening, which has got sensitivity up to 93% with a false positive rate of 2.5%. So if someone has done a good double marker test, good means a good anti-scan and a biochemical from a good lab. So you have done a test which is 90%, let's talk 90% sensitive or accurate. Now, doing a quadruple marker which is 75% accurate is like giving an 8th standard examination after you have already passed a 10th standard examination. Doesn't make sense. So in case it has come high risk, a double marker, you need a confirmatory test. There is no fun in doing a quadruple marker test which is still again a screening test. Once you have a high risk, go for a confirmatory test, and that's how it should be. Intermediates can have a NIPT, but again you have to individualize and
so where does the quadruple marker stand now? When would be indicated?
Well, say I would put in a totally different way. Maybe you may think me as ahead of the time. But then when you have a test which has an accuracy of 99%, why you are going for a test which has 80% and 90%? Say it is all linked with the economy also. People pay from their pocket in our country. It's not like the US or America where the insurance company pays or the NHS pays. See, after if you calculate the cost of doing the double marker and then the quadruple marker and then the ultrasound, and at the end you are getting a 90% result. What does 90% mean by is, if I do all this exercise and I tell that you are screen negative, that means you have excluded 9 out of 10, but still one remains. If that one baby is born to that patient after delivery and she puts you in the consumer court that after doing that test, I got a Down's baby, what answer you have? And judiciary is not that sensible to understand all this 90 and 80 and 100. Judiciary would say that after doing this Down's baby is born, so you pay the compensation. They don't have that much of orientation or intelligence to interpret all this. So why not to offer the NIPT, which they are, if they are affording, why to offer these markers? I am of that opinion. I have stopped doing all these tests. The other reason for stopping all these tests is the non-standardization of the laboratories. None of the laboratories are using the Delphias or the other machine, Cryptor, and those kind of things. Those kits, they come from the China. Our transportation errors are there. See, you know that the PAPE will decrease if the blood sample is preserved for more than 24 hours. If the beta HCG would increase if you store the blood for 24 hours. And all our samples never reach the lab before 24 hours. Ideally, they are to be processed within 8 to 12 hours. Then only you will have a reliable readings, reliable reports to interpret with. Already the transportation error is there, the kit error is there, the instrumentation error is there, your NTs we see around, they are not the way they are to be done in 70 to 80% of the patients, and then you are calculating the risk. So if after doing all this, if a Down's baby is born, what is the fun in doing all this? So it's better to offer the best. If the patient says no, that's a different thing, then you offer them a thing which is less than what is standard. That is my personal opinion. Not that everybody will agree, but I practice this way. I stopped doing all these markers now.
तुमचं ओपिनियन बरोबर आहे, कारण आपण सगळ्या टेस्ट ऑफर केल्या तरी एकाही रिझल्ट मध्ये असं 100% कशाचंही निदान नसतं. आतापर्यंत प्रत्येक वेळेला रिस्क सब काय थोडी रिस्क आहे, लो रिस्क, मिनिमम रिस्क असेच रिझल्ट आहेत प्रत्येकाचे. तर पेशंटला त्याच्याशी काही देणं घेणं नाहीये. पेशंट विचारतो माझं बाळ चांगलं होणार आहे का नाही तेवढं सांगा.
बरोबर आहे. After you get an intermediate risk or a high risk, again you have to do an invasive. That is a different cost.
Because double marker adds only up to 15% of what a good NT scan has been done. So even I have not been using double markers. 5%, yes, sir, so to be accurate. So if your NT NB is giving around 80%, 85% risk, double marker is going to add only for 5%. So doing this biochemical test is a great halla gulla. Even we never used to do in our era. पण वी वर फोर्स टू डू की आमच्या काही लोकांना चालू करायला, कारण हे येणारे आमचे पुण्याचे जावई मला सांगितल्याप्रमाणे तुम्ही आम्हाला डबल मार्कर नाही सांगितलं, तुम्हाला क्वाड्रुपल मार्कर नाही सांगितलं, मग आमच्या तिथल्या पॅनलने असं सांगितलं होतं. इट हॅपन्स, काउन्सिलिंग करतो, पण ते म्हणाले करायचे तर करून दे. म्हणजे वी आर नॉट अगेन्स्ट डुईंग इट, पण त्याचे लिमिटेशन्स आपल्या सगळ्यांच्या लक्षात येणं गरजेचं आहे. ना अबाउट NIPT, आपल्या सगळ्यात NIPT डिस्कस झालं नव्हतं. फ्यू थिंग्स मोर अबाउट NIPT. Ajit Gandhi sir, since you are using NIPT, can you elaborate little more on NIPT, when to be done, what does it diagnose, what is its sensitivity, and what are its limitations?
Well, so primarily I depend on the risk calculated by the NT scan. In the NT scan, I use the NT, NB, DV, and if required, the additional markers, the FMF angle, the tricuspid regurgitation, and that gives you almost precise risk whether she is screen positive or negative. Now the question comes when to do the NIPT. If you are finding a significant marker in the NT scan, say for example you are finding an absent NB, or your NT is more than 95th centile, or if you are finding abnormality, say for example say single umbilical artery or like this, then there is no fun in doing the NIPT. Then straightway you go for a invasive test. And of course with all these markers your screen is going to be positive, and then you go for the invasive test. Selection of the invasive test will depend on the findings, patient's age, the previous obstetric history. If he happens to be 35 years and if I find these abnormalities, certainly I would do an invasive test and a microarray. If I am finding this at the age of 20, perhaps I would do only FISH, look at the 5 important chromosomes and close the chapter over there. So your decision-making process is a complex process. There is no a fixed protocol. You take into account all the variables and then you come to the conclusion as which is the best test. Okay, and in case if you don't have a orientation about all this, if it is screen positive and if you wish to have only one test, go for a microarray which will answer you almost all the problems related to chromosome.
Sir, about NIPT?
Yes, NIPT, the NIPT detection rate varies. Detection rate for trisomy 21 is the best. It is about 99 to 99.5% positive predictivity. The false positive rate is less than 0.5%. For trisomy 13 and 18, it is between 92 to 98%. And it performs badly for the sex chromosomal aneuploidies, where it is between 88 to 94%. So you are likely to miss those aneuploidies when you use the NIPT.
So NIPT is to be added to your first trimester scan, or NIPT is to be done independent?
In NT plus NIPT. And if NT is abnormal, invasive. No markers.
NIPT still not a diagnostic being.
It is a screening tool.
Screening tool.
If you find the NIPT is positive, you have to go for an invasive test and confirm it. Recently, I had a case, NIPT was showing a trisomy 21. We did the invasive. It turned out to be a mosaic 21. Still, it was mosaic, but then it was mosaic 21.
In our periphery, many times what happens, that patient comes with NT report, maybe done somewhere, not a FMF accredited center or something like that. NT is 2.5, NT is 3, and they come and sit on our head that we straightway want a termination. Now, what to do in such conditions? Dr. Sumit.
Get a repeat scan done if she is less than 14 weeks. NT scan, a repeat scan is not going to charge again much, rather than directly. On the other hand, terminating the pregnancy will cost her 20,000, 25,000. Take a second opinion from someone who is expert in a NT scan, and then the counseling has to be done by the fetal sonologist or the person, and accordingly we have to take a decision.
Now, what I wanted to make it a point that NT done increase risk, but before terminating, do we need to go for an amnio and then terminate, or we can go for termination with these much amount of findings?
2.5 NT is first and foremost, 2.5 is no cutoff. If 2.5 is at 11 weeks, then it is significant. 2.5 is not at all significant at 13 weeks. So we need to know at what CRL we have got, whether it is going beyond, as sir said, whether it is going beyond 95th centile for the period of gestation. So first and foremost, that is important, whether we are dealing with a normal NT or it's abnormal. In case it is abnormal, now the FMF says that if the NT is beyond 95th centile, like from 3.5 mm to 4.4 mm, 20% are going to be chromosomally abnormal. So what about the 80%? They are going to be normal, no? Why do you want to terminate the pregnancy directly? You have CVS, you have amniocentesis, they are not very costly procedures. Around 18 to 20,000 you can do amnio with this thing, microarray. So that should be the thought process.
So to summarize, I would like to say that before taking a decision for termination, or whenever we order a test, we have to counsel the patient that this is a screening test. This is not a diagnostic test. This is not going to tell you yes or no. And if the screening test comes high risk, we have to explain that when it says high risk is 1 in 100. That means though it is high risk, it means that 99 babies are going to be normal and only 1 baby is going to be abnormal. So we need not terminate the pregnancy. We need to confirm the diagnosis, see that the baby is normal or abnormal by amniocentesis or CVS, what is available, and then take the decision for termination. Because many times in a hurry, if this has been seen by some general practitioner or maybe some person who is not very well with the fetal medicine foundation or fetal medicine, then he is very likely to give us opinion in a way, terminate kara. So we have to tell the patient that this is a screening test, not a diagnostic tool. A diagnostic tool has to be used, diagnosis has to be made, and then the decision of termination can be taken. Okay, thank you so much for answering those queries in detail. And the academic session of this CM is over now. Now I hand over to the organizers for a vote of thanks. Dr. Rasika Kulkarni giving a vote of thanks.
Good afternoon, everyone. On behalf of Pandharpur Obstetric and Gynec Society and organizing team, it's my privilege to propose the vote of thanks on this occasion. My heart fills with a lots of gratitude and respect for our guests and speakers for sparing their valuable time with us and also enlightening us with their commendable talk. Thanks all of you for clearing our all doubts and concepts, enhancing our understanding pertaining to fetal medicine, ultrasonography, genetics. I would like to thank the KEM Hospital Fetal Medicine team and all the speakers, Dr. Pooja Pabaye Madam, Dr. Shripad Karade Sir, Dr. Ashwini Jaibe Madam, Dr. Shweta Gugle Madam, Dr. Chaitanya Datar Sir, Dr. Sumit Chamriya Sir, Dr. Ajit Gandhi Sir, Dr. Umbardhan Sir, Dr. Meenal Agarwal Madam, Dr. Rajiv Dabde Sir, Dr. Archana Shah Madam, and Dr. Revati Rane Madam. My heartfelt thanks to our IMA President, Dr. Sunil Karande Sir, and IMA Secretary, Dr. Deepak Dhotre, and whole IMA team for continuous support. Thank you to the Indian Red Cross Society Pandharpur branch for allowing us for CME arrangement in their space. Special thanks to the sponsorer, Leliac Insights, caterers, Mr. Pappu Nae for breakfast and Hotel Radhesh for delicious lunch. Mandap arrangement by Mr. Rajguru and audio-visual arrangements by Mr. Lavekar. Special thanks to organizing chairperson for today's CME, Dr. Sudesh Doshi sir, and organizing secretary, Dr. Sachin Pawar, and whole Pandharpur OBGY team for the great success of CME. Last but not least, thanks to all delegates and my doctor friends for their patient hearing and making the CME successful. Thank you for cooperation and support. Thanks.